Now, sir.
Good evening. President Urological Society of India, Professor Anand Kumar, Chairman Indian School of Urology, Dr. Rajiv Sood, Co-Chairman Indian School of Urology, Dr. Arun Chawla, Convener of today's program, Dr. Rajesh Taneja, esteemed international faculties and national faculties, past presidents of Urological Society of India, members from USI, residents and members from SAARC countries. A warm welcome to all of you to today's webinar. This is a Saturday School in Urology, an initiative of USI in collaboration with Alkem Pharmaceuticals. It is supported by an educational grant from them. And today, as a part of the Saturday School in Urology, bladder pain syndrome, interstitial cystitis, and evolution. The convener for this program, Dr. Rajesh Taneja, has charted out an interesting program on a topic which is quite difficult. It is not uncommon, but it's a great problem for those who suffer from it, and most of the conditions are diagnosed by exclusion. So this is a condition where a proper history, evaluation, and proper attention is required for the appropriate management of the patient. So the faculties from international faculties and national faculties will deliberating on the various aspects associated with bladder pain syndrome. And today it will be a treat to hear from all of the eminent faculties. With these few words, I welcome you all and wish this webinar a grand success. I would request the President of Urological Society of India, Professor Anand Kumar, to say a few words. Over to you, sir.
Good evening to all my friends and good morning to my overseas international faculty, and especially Dr. Phil Hano, Dr. Sander Lavaz, Dr. Maros Servigni, and Dr. Jensen. And we are very thankful that they have joined in early hours of the day to this wonderful webinar. Bladder pain syndrome and interstitial cystitis is a very frustrating disease for the patient as well as for the treating doctors. You have to be very great listener to listen to their problem and then take care of them. You need your all the skill, social skill, psychological skill, and your technical skill as well as your knowledge to help them out. And these patients go from one doctor to other doctors and they have variable response depending upon the therapy is given. And because of this, many doctors do not like to treat it. But these patient needs experts and specialized doctors who can look after that. And I'm very happy that we have a specialized doctor who dedicate themselves to treat such patients and look after them, and because they need a specialized care. And I'm very sure that this webinar with international faculty will explore various aspects of this disease, how to diagnose, how to treat them, how to counsel them, how to follow them, and what is the best they can provide to these patients. And this knowledge is very important for all the members because these patients are all over the country and they go to the available urologists there. And at the same time, I would like to wish you all a good health, stay safe, take care of yourself. As you know that next wave is already around, and especially in major cities, it is becoming difficult. Nowadays, in most of our hospitals, a lot of COVID patients are there, and non-COVID patients who needs treatment are not getting bed. So be careful. We need you to take care of your patients. And with this, I welcome you all again to this wonderful webinar. And I would like to thank on behalf of USI to all our international faculty for joining us, enlightening us, and getting up early in the morning and joining this webinar. Thank you very much. And back to Dr. Rajiv TP.
Thank you, sir, for your enlightening words. Now I would request Professor Rajiv Sood, Chairman, Indian School of Urology, to say a few words. Over to you, sir.
Good evening, everybody. Thank you, Dr. Rajiv, President USI, and my co-chair, Dr. Arun Chawla, and the eminent international national faculty. I recognize the presence of Dr. Phil Hanov, Dr. Dick Jensen, Dr. Mauro Cervigni, and Dr. Sandoz Lovas. And it is difficult to call all the names of all the Indian faculty, but that is important that Dr. N.P. Gupta, I think, is the senior most amongst us. Various practitioners like Dr. Nagendra Mishra, Sanjay Panda, Anita, so many names are there. I'll not, you will be introduced to all of them, but the national and international delegates who are attending. And this topic is of great interest and also widely debated on various issues, and every time the discussion change. I have witnessed in last 1.5 decade or so that the nomenclature, honors ulcer, the importance, presence, absence, or ablation, or the intravesical treatments which are coming. I am the member of Drug Controller General of India panel, and there we had given the approval for the medicines in India, like your Camphora and also now intravesical treatments. The initial approval has been given. So I was the part of that panel. And this is a great interest as an uncommon condition. It is not uncommon, but as uncommon condition, we have given fast track approvals. It is uncommon because diagnosed with difficulty. Gynecologists think that patient is to be referred to urologist, and urologist at the lower level, sometime at resident level, the patient is disposed of diagnosing something else. It is very important topic and of interest, and everybody is facing in the clinics, and I'm sure that great attendance is going to be there today. In this Saturday School of Learning, we are covering very interesting topics, and when it is studied with the international and national eminent faculty, Dr. Sanjay Sinha, Dr. Sanjay Pandey are also there. The guidelines are being framed. Dr. Rajesh Taneja has who is the chair of ASICS and also chair of the Global IC BP Society. And also, right from the beginning, Dr. Nagendra Mishra, and now Dr. Amita, they all are so passionately following it. And you need such leadership to follow this important disease entity, and also to research, to frame guidelines, and also in the Indian perspective. So I wish all the best for this webinar, beautifully crafted program, and so many eminent people are going to brainstorm all the aspects threadbare in this, and it will end with the panel discussion. I'm sure that this is going to be one of the flagship webinars of our whole year's program. Wish you all best of luck, and I welcome all the delegates who have already joined or are going to join in the course of the webinar. Thank you very much.
Thank you, sir, for your kind words. Now I would request Dr. Rajesh Taneja, the convener of today's program, to take over the further proceedings. Over to you, Rajesh.
Thank you very much, Rajiv. And first of all, I must thank the Urology Society of India, Dr. Anand Kumar, Dr. Rajiv TP, and the Indian School of Urology, Dr. Rajiv Sood and Dr. Arun Chawla, for giving me this opportunity to convene this topic as a webinar. And it is really a privilege to have the international faculty. Phil Hanno has been writing the chapter of interstitial cystitis in our Bible of urology, the the Campbell's urology for the last more than 3 decades. So obviously we have the stalwarts here. Dr. Maurice Ervini is a renowned urogynecologist from Italy. Dr. Dick Jansen, and he's from Netherlands. And these people are the people who are doing research at the subclinical level. And so is my friend Sander Lovas from Hungary, and all the national faculties. As we go around, we'll see. The reason for getting this topic was that it is one of the ignored, not necessarily intentionally ignored topic in the medical training, right from the graduate, postgraduate, and super specialty levels, because we have more pressing issues to be taught, more pressing issues to be dealt with, and this somehow gets a backstage. But today we are going to have a kind of update as what is on the horizon across the globe, and that's how we have this webinar. It is divided into 3 parts. The first session has 4 lectures and a question answer session. And of course, the expert comments. And then the second session, and then there is a panel discussion. So I start with inviting the next part, that is the faculty. So I will invite the chairpersons for the first session. The first one and the foremost is my teacher, Dr. Narmada Prasad Gupta. He is the former head of the department, All India Institute of Medical Sciences, and is currently the chairman of Kidney and Urological Institute at Medanta Medicity, Gurgaon. He has more than 40 years of experience in the subject and has been awarded a very highly prestigious civilian award by the Government of India in the year 2007, the Padma Shri, and also the highest medical award, Dr. B.C. Roy National Award in the year 2005, and many more. He has published a lot of peer-reviewed literature in addition to having published a book all about the prostate gland. The next chairperson is Dr. Atul Shah. He's a dear friend who has witnessed the evolution of GIBS, the Global Interstitial Cystitis Bladder Pain Society, ever since our first meeting in 2016. And he's a senior consultant urologist at the Nilgiri Hospital, Mumbai, India. And the third chairperson is Professor C.S. Ratkal, again, a very senior urologist from South. He has been the director of the Institute of Nephrology and Urology under the Government of Karnataka, India. And after retiring from that post, he is currently professor and head of the department at Boring Hospital in Bangalore, India. He is the present president of the Association of Southern Urologists of India. With this introduction, I would like the chairpersons to take charge while we will have the speakers' CV on the screen. Welcome, chairpersons. Please take charge, Dr. Gupta sir.
Thank you. Yeah, thank you, Dr. Taneja, for your kind invitation to join for this webinar on a difficult topic, I will say. And along with my co-chairpersons, Dr. Patil and Dr. Ratkal, we welcome you all to the first session in which we are going to have 4 lectures. And to start with, the first lecture is by Dr. Philip Hano, who does not need any introduction because he has been part of our various scientific activities as well as conferences in India. And he is going to talk on enigma of nomenclature. Just to introduce to our younger colleagues, he is the clinical professor of urology at Stanford University School, USA, co-chair of the medical advisory board of the Interstitial Cystitis Association, executive board of International Society of Study of Bladder Pain Syndrome, and he has studied bladder pain syndrome both from a basic science and clinical perspective. With this brief introduction, may I request Dr. Philip to please give your talk on the enigma of nomenclature.
Thank you very much. I am very happy to be here and discuss this interesting issue with all of you. My talk is on the enigma of nomenclature. And nomenclature can go back to 1808 when Philip Singh Physic in Philadelphia called an inflammatory bladder condition with ulcer.
Phil,
With
can you share your screen, sir?
I'm sorry, it's not shared. I thought it was shared. I apologize. Hang on. It's green, shared screen. You don't see it?
No, unfortunately not.
At the bottom, there is an icon share screen, so you can.
I have it.
And
It says,
then select.
Okay, okay. There we go. Did you see it here?
Yeah, now we can.
Okay, I don't know what my mistake. Can you see it now? Okay.
Yeah, we can.
Okay, so here we go.
You can make it a presentation because we are seeing all the slides.
Right, and you're not seeing the presentation right now?
Yeah.
All right. I'm going
Make it
to
full screen, sir. Make it full screen.
The slideshow.
Slideshow full
Okay.
screen. Yeah.
You see it now?
Yeah, this is.
All right, you see the presentation, full screen?
No, still you have to make a full screen.
All right. I'm trying to.
The slideshow. You have to click
I
on.
know. Yeah, I apologize for this. I'm not getting. Here, let me end the show and start it again here. Okay, here is full screen. You okay now?
Absolutely fine.
Okay, sorry about that. And let me just get all these pictures off of this screen here. All right. So.
There is an arrow in the bottom. Yeah.
I got it. Okay. Sorry, I apologize. It's 5 in the morning here. I guess I've got 2 screens going on here. It's messing me up. So Philip Singh Physic described an inflammatory bladder condition with ulcer with symptoms similar to bladder calculus. And that was the first description in 1808. Joseph Parrish in 1836 described tic douloureux of the bladder, a nervous affliction characterized by severe suffering. And in 1836, Louis Mercier, who was the urologist who invented the Coude catheter, described ulcus simplex vesicae, destroying each layer of the bladder wall. It wasn't until 1876 when Samuel Gross described an interstitial or parenchymatous cystitis, mucosal cystitis if superficial, that the name interstitial cystitis appeared. And at this time, it was a description, not a disease. In 1878, Alexander Skene called the disease IC, or interstitial cystitis, an inflammatory process with ulcer. In 1917, Hunter described the Hunter lesion, and he called interstitial cystitis a peculiar form of bladder ulceration whose diagnosis depends ultimately on its resistance to all ordinary forms of treatment in patients with frequency and bladder symptoms or spasms. And Hunter is the person who popularized this diagnosis of interstitial cystitis. So we give him a lot of credit from 100 years ago. In 1949, J.R. Hand described small discrete submucosal hemorrhages and dot-like bleeding points, which were characterized by Anthony Walsh in Ireland in 1978 as glomerulations. And that's when it first appeared in Campbell's Urology. In 1978, Messing and Stamey wrote a paper that was extremely influential, and they moved from what Hunter described as interstitial cystitis to a much broader diagnosis. They said non-specific and highly subjective symptoms of around-the-clock frequency, urgency, and pain, somewhat relieved by voiding when associated with glomerulations upon bladder distension under anesthesia. So this really is about the time when things started to go wrong. And in 1987, the NIDDK held a workshop with urologists from many parts of Europe and North America and developed the NIDDK criteria to define research parameters of interstitial cystitis so that clinical and basic research findings would have a common basis for comparison. They were not meant to be de facto definitions for the clinician. There was actually no requirement for pain in the NIDDK criteria. And the problem with this meeting was not so much the NIDDK criteria, which were just defined for research purposes, but the meeting accepted the broad encompassing definition of interstitial cystitis in the absence of any data supporting that this is all one entity. So the key finding in the NIDDK IC database study, which came after that NIDDK meeting, was that yes, the NIDDK criteria were very helpful in terms of meeting what they were supposed to do. They identified a group that everyone agreed just about had interstitial cystitis, but they missed 60% of the patients. 60% of people who experts thought had IC were not identified in the criteria. So they could not be used clinically, only for research purposes. But the NIDDK accepted that IC is an inclusive diagnosis of exclusion. That it had a very broad definition. And the only person who came out against this wrote a paper. This was Magnus Fall from Sweden in 1987. And no one paid much attention to his paper. But in this, he said, Hunter lesion disease should not be evaluated with non-Hunter disease in clinical studies. ESSIC was formed because of some of this confusion in the early 2000s, and they've written several very important papers. One of the most important was on diagnostic criteria, classification, and nomenclature, and I'm sure you're all familiar with this paper in the European Urology Journal. And then in 2008, the AUA developed a guideline for ICBPS, which defined it as an unpleasant sensation, pain, pressure, discomfort, perceived to be related to the urinary bladder, associated with lower urinary tract symptoms of more than 6 weeks duration in the absence of infection or other identifiable causes. There was no requirement for a Hunter lesion, and there was no requirement for glomerulation. So let's go to phenotype for a minute. Regardless of what we call it or how we define it, phenotyping may hold the key to improving treatment outcomes and facilitating research. And the only proven phenotype in 2020 is the Hunter lesion, which defined the disease 100 years ago. There are only a few anecdotal examples of a non-Hunter lesion patient assuming this phenotype, and the patient population seems to be different than non-Hunter patients. In the first place, there's a histological distinction between the subtypes with and without Hunter lesions. One is an inflammatory disorder, and the other, in many cases, is a non-inflammatory disorder. The histopathology of a Hunter lesion includes granulation tissue in the lamina propria, fibrosis in the detrusor muscle, mast cell count increase and mast cell migratory capacity, lymphocyte activation patterns, plasma cells and macrophages with inflammatory infiltrates in proximity to intramural nerve fibers. These are all findings when you look at the histology of Hunter lesion that are rather unique. And if we look at the patient groups, we see differences as well. The Hunter patient has a mean onset at age 41 to 55. The mean onset of non-Hunter is 30 to 42 years of age. The response to cyclosporin is up to 85% in Hunter lesion patients and as low as 11 to 30% in non-Hunter lesion patients. The response to full duration resection and steroid is well known for Hunter lesion patients, and this is not the case. There is no response in the non-Hunter population. The pathology, as we've already said, is distinct. While the pathology in the non-Hunter patient is variable and may be absolutely normal. There are fewer comorbid conditions in the Hunter lesion group than the non-Hunter, and the anatomic bladder capacity under sedation is lower in the Hunter lesion than in the non-Hunter. So there are major differences. So in a sense, we've come full circle. In 1915, Hunter described the Hunter lesion as the hallmark of the disease interstitial cystitis. By 1978, it became more inclusive, and all you needed was symptoms and glomerulations. In 2011, you didn't need glomerulations anymore, and we had a very broad definition of patients who just had urgency and frequency with no other obvious cause. Now in 2019, we're looking at Hunter lesion as a disease in and of itself, not just a phenotype, but perhaps it should be considered a disease separate and apart from bladder pain syndrome as we think of it. And we now know that glomerulations are not important in terms of clinical decision-making or identifying a separate group of patients. They don't really help us, so we don't worry about them anymore. And the landscape has really changed. 2017, the International Consultation on Incontinence pulled Hunter lesion out of the bladder pain syndrome group and identified it as a separate disease. Ken Peters' group in Michigan wrote, "We believe Hunter lesion IC is a distinct disease and therapy should focus on the bladder." Akiyama in Japan said terminology should be developed to refer separately to Hunter lesions. This is reflected in the Japanese and East Asian guidelines. And Nordling and Fall and the ESSEC group wrote a paper just this year saying it's time to accept that classic IC with Hunter lesions and BPS always should be evaluated separately in science as well as clinical routine. And these are the Japanese guidelines. And you see here that Hunter lesion is separated out with a flexible cystoscopy very early on in the diagnosis of the syndrome and considered separately. So these are difficult issues to contend with. Is bladder pain syndrome best looked at as a syndrome, an end-stage response of the bladder to what may be many causes or diseases? There's a wide range of response to therapy and natural history. It's a collection of symptoms. Is Hunter lesion best looked at as a disease, clinically indistinguishable from bladder pain syndrome, but it does not evolve from bladder pain syndrome. It has a distinct appearance, distinct histology, and distinct response to many therapies. And should BPS and IC be differentiated in all pharma trials? Well, yes, I think so. Viewed as one entity, we have failed to find convincing responses to a variety of attempted therapies in decades of trials. The use of local cystoscopy makes differentiation practical and inexpensive, and the guideline should ultimately reflect this change in thinking. So here we have a normal bladder, glomerulations, and then a Hunter lesion pre and post distension. And to believe this disease, this is one disease in the absence of confirmatory data, strains credulity. So to conclude, once upon a time, Guy Hunter described Hunter lesion disease, interstitial cystitis. 50 years later, patients with similar symptoms but no obvious cause were included in the diagnosis without data. Progress was limited, drug trials failed, everyone was lumped together, Hunter lesion patients went undiagnosed. It's time for urologic associations to make Hunter lesion a disease. It's time for governments to give it its own coding, and insight into an obvious fact has been late in coming. Thank you.
Thank you, Dr. Philip. It was always a dilemma for us about the nomenclature of this disease, but you have very nicely described the history and how the terminology has changed. May I request my co-chairperson, Dr. Patil, to please introduce the next speaker, and we will have question answer at the end of all 4 lectures.
Thank you, Dr. Gupta. Dr. Atul Shah here. The next speaker is Dr. Uttam Mete. Rajesh, can we have the speaker's profile on the screen, please? All right. Thank you, Dr. Rajesh. The next speaker is Dr. Uttam Mete, who is a professor, Department of Urology, PGI MER, Chandigarh. He's a founder, core member of GIBS, with us right from the beginning. He is member of many national and international societies like USI, North Zone USI, AUA, SIU, and IMS. He is a former secretary of North Zone of Urological Society of India, and he has special interest in laparoscopy, robotics, endourology, uro-oncology, and urolithiasis over and above bladder pain syndrome. Over to you, Dr. Uttam Mete. Your talk time is 12 minutes. You can share your screen, sir. Yes, you're visible, only full screen, sir.
Good evening, everybody. And thanks to USI ISU for giving me this opportunity, and thanks to the chairpersons. So my topic is the pathogenic pathways of ICBPS, bladder and beyond. See the definition of this condition. It has got three components: symptoms, chronicity, and absence. So the most important part is the pain and chronicity. So basically we're dealing with a patient with a chronic pain syndrome. So what we know and what we do not know. What we do not know is we really do not know what is the cause for this disease and what are the pathogenic mechanisms for this disease. What we know is that it is multifactorial and multiple pathways are involved. So far, the research has focused only onto the bladder, but now we are thinking it is not really limited to the bladder. The pathology is beyond the bladder. Beyond the bladder may be the neighboring organ like genital, GI, or pelvic floor, but most commonly it is a distant organ pathology in the CNS, or definitely contributes for the chronicity. Now, as Professor Hanno has already mentioned, that the light microscopy, immunohistochemistry, or electron microscopy might show some changes in few of the patients of ICBPS, like denudation or ulceration, or hemorrhage in the lamina propria, or inflammatory cell infiltration and mast cell infiltration in the bladder wall. But none of them are specific, not the pathognomonic for ICBPS. Now, there are several pathogenic mechanisms have been postulated. The most commonly postulated etiology are infection, autoimmunity, mast cell activation, urothelial dysfunction, and neuroinflammation. I'll go one by one, but the 3-4 molecules which are most widely described and is really being used for clinical purposes are APF, nitric oxide, ATP, and now growth factor, the NGF. Now, whenever there is an insult to the bladder, be it infection, trauma, whatever it is, the bladder is going to respond. Now, how it is going to respond? It is going to respond by activating the mast cell. It is going to respond by changing the permeability of the urothelium. It is going to respond by C fiber activation or immunogenic and allergic responses. Now, what is the response of this? We all know that that will lead to an inflammation, and inflammation should lead to a repair. But if repair doesn't take place, there will be progressive injury, and that progressive injury will lead to BPS with or without Hanna's lesion. Now, so far we know that it was actually confined to the bladder, but we are thinking now, or the recent research is, it is beyond the bladder, which acts on the central nervous system, and I'll discuss in details about those things. Now, coming to the epithelial barrier. Now, you see the normal epithelium, we have the urothelium, which is multi-layered, the basal layer, intermediate layer, and the umbrella cells, the superficial layer, and they are all having some junctional protein, the surface protein, that is a uroplakin, the basal protein, like the collagen, and of course, on the top of it is the gag layer. These gag layers prevent entry of urinary constituent into the subepithelial space. Now, what is gag layer? You can see the biochemically, they have a central core of protein, and they are coupled with this carbohydrate moieties. This includes the heparin, hyaluronic acid, chondroitin sulfate, keratin sulfate, and dermatan sulfate. And it makes the barrier for the entry of any urinary constituent into the urothel, into the underlying bladder wall. Now, do we really have any proof? Yes, it has been proven by different ways. Some permeability tests have been done in different research aspects. People have instilled intravesically urea, potassium chloride, DTPA, and other fluorescent dye. And if the bladder is really leaky, their absorption will be more compared to the control patients, and their concentration in the blood is more. And it has proven, yes, it is there. Now, there are several studies which have been conducted to see whether these patients of ICBPS has got gag abnormality or not, and the research says that a mixed outcome. It may or it may not be there. Now, what is the consequence of this gag deficiency? There will be increased permeability, which will lead to the intrusion or entry of the ion solutes and pathogens into the subendothelium, leading to the triggering of inflammatory reactions, mast cell degranulation, activation of C fibers, and increased production of nitric oxide and other molecules. What are the functional abnormality of the urothelium? I'll go later on. One is the APF, antiplatelet factor, that I already told, that if there is a damage to the bladder wall, it is supposed to be get repaired, but these patients' epithelium does produce a factor that is called antiproliferative factor, which prevents the repair mechanism, leading to the persistence of this nociceptive stimulus. And how does it work? It works by upregulation of the P53 or downregulation of the HB-EGF or upregulation of EGF and IGF, leading to non-repair of this non-proliferation of the urothelial cells. Second question was the infection. Has infection been any role played by this pathology? People have tried to find out whether gram-positive, gram-negative bacteria, atypical bacteria, some viruses or fungus, and they have tried to find out all these organisms by culture of the urine as well as the tissue, as well as the nucleic acid amplification test. Now, what are the results? The result says that none of these bacteria, whether it is gram-positive or gram-negative, has been found to be associated with this disease. The most important study which I like to tell upon is the RCT by Warren's Perspective study. And these studies in 50 patients were actually given sequential antibiotics for 18 weeks, but none of the patients of ICBPS really had developed any benefit. So that's why that is the end of saga of infection as a cause of ICBPS. So the summary is that it is unlikely that active infection is involved in the ongoing pathologic process or that antibiotics have any role to play for the treatment. Second is it an autoimmune disorder? There are some direct evidences like patients with ICBPS, if you take the blood and do the immunoglobulin level as well as plasma cells in the blood or the cells in the bladder wall, like Professor Hano's article says that they had found some CD4-CD8 ratio alteration in the bladder biopsies. There are presence of anti-nuclear antibody as well as anti-bladder antibody. These are the direct evidences, but these are all supportive evidences. But at the end of the day, we can conclude that most probably it doesn't play much role for the pathogenesis of these patients. There are therapeutic responses with sublatus tosylate, which is an immunoregulator, and it has been found that few patients only get benefit. So the summary of BPS as an autoimmune disorders, the exact role of autoimmunity in IC remains controversial. If at all there is, it is the partial. The third most common pathogenetic mechanism is the mast cell, involvement of the mast cell. As you all know, that the mast cell has got granules. When they degranulate, the substances come out from these granules, and commonly it is a cytokines or a chemokine or a growth factor. What will happen? When they come into the environment, they'll go or attack the vessels, leading to inflammation, meaning thereby there will be dilatation of the vessels, exudation of the fluid, and this lymphocyte or the leukocytes exudations. And they will also activate this C fiber producing pain. And not only that, the histamine which is released by this degranulation is responsible for fibrosis. Now, when these mast cells, they degranulate, they release the histamine, other substance, which in turn will stimulate this C fiber, and C fiber will release the substance P, and that substance P in the return will release or stimulate the mast cell. So this is a vicious circle. So this mast cell, these nerves and the vessels, they are in a strategic position and they are interrelated, and one's function is usually controlled by others. So what is the summary? Summary says that histopathology shows there are detrusor mast cell. People have compared the mucosal mast cells versus detrusor mast cell, their ratios, whether these mast cells are activated or resting mast cells. And people have also seen that the products of mast cells in the urine, histamine and methylhistamine, to prove that the patient is having an IC or BPS. And what is the summary of all these studies? They said that most probably it plays the central role for the pathogenesis of ICBPS by sensory nerve stimulations, releasing the mediators of inflammation, and they augment the urothelial apoptosis, leading to leaky urothelium. But the most important theory is the neural theory. Now, what happens if you see the normal pain pathway? Whatever nociceptive stimulus is there in the bladder, it is first being carried by the C fibers. And the nucleus of the C fibers is located in the dorsal root ganglion. And then it synapses with the dorsal horn. In the dorsal horn, when it synapses with the second order neuron, and this nerve stimulus or the pain stimulus, it goes via this ascending pathway to the thalamus. From the thalamus, it is being protected in the brain. On the other hand, there are descending pathways, that is the regulatory pathways. The descending pathways, fibers are located in the periaqueductal gray matter or in the medulla, and they come, and what do? They usually synapse with the interneurons. The interneurons, they release the inhibitory neurotransmitter to inhibit this second order neuron, or they produce the enkephalin, and that will reduce the pain. So the balance between the ascending and the descending pathways are responsible for proper pain perceptions. Now, what happens in these patients of ICBPS? There are changes in the afferent nerve. There will be cross sensitization, sympathetic nerve activity, the changes in the spinal cord, and changes in the brain. I'll go one by one. So what is the purpose, or what is the main function of these sensory nerves? The sensory nerves, usually it releases the substance P, neurokinin, and CGRP in the patients in the presence of some nociceptive stimulus. That is called the neuroinflammation. That means the nerve is releasing the neurotransmitter. This neurotransmitter in turns is acting on the vessels, producing vascular hyperpermeability, leukocyte adherence, and edema. And also it acts on the mast cells, producing degranulations, and this perpetuating the cycle. This is the neuroinflammation. And normally this inflammation should stop, but if there is a repetitive stimulus, the repetitive stimulation leading to some changes in these nerves. These changes may be in the form of receptor, changes may be in the form of upregulation of this neurotransmitter, as well as excitability. So what are the changes? If you see, because time is very limited, so that what is the outcome of these changes? Changes is these peripheral nerves become hyperexcitable, and there will be expansion of pain field, which is perceived by a single neuron. Not only that, that will not only sensitize only one afferent neuron, it is going to sensitize the neural pathways. As you all know, that is the basis of pelvic organ cross-sensitization. The neural pathways from two or more organs, they may converge. So transmission of noxious stimuli from a diseased pelvic organ to an adjacent normal structure, resulting in the occurrence of functional changes in the latter. That is the cross-sensitization, and it has been found. That's why patients with ICBPS, some sort of food or some specific foods might usually induce the pain in the bladder, and that is the basic physiology of cross-sensitization. Now, what happens in the spinal cord? There are 4 or 5 things happens in the spinal cord. One factor is the wind-up. What is wind-up? And normally, when the afferent neurons, it goes into the spinal cord, usually it synapses with the neurons of the outer layer of the dorsal horn. And now, the dorsal horns, actually the nerves are arranged in layers. That is called the organization. Now, once there is a repetitive stimulus, this organization is lost. That means zone 1 cell will not cross to the zone 4. And if this crosses, this is called disorganization, or that is called sprouting. And not only that, the substance P, which is produced more, it will go, rather than to the second order neuron, there will be a reverse flow. Reverse flow means it flows through the afferent nerves into the bladder, again producing the bladder inflammation. And in addition, there will be increased NMDA and AMPA receptor overactivity and increased glutamate, which is the stimulatory neurotransmitter. And in addition, few of these afferent nerves will stimulate the sympathetic fibers in the intermediolateral part of the spinal cord. Not only that, I have already told that the pain regulation, we have the descending pathway, which is basically inhibitory pathways, and they will have some effect on this inhibitory pathways also. And that's why there will be less inhibition of the pain. So what is the clinical outcome of this? The clinical outcome are 2. One is allodynia. That means in absence of any stimulus, patient will feel pain, and hyperalgesia. That means a small or low intensity pain will be perceived as very high intensity pain. So these are the changes in this.
Humble request to wind up now, sir.
Okay, and there are a few slides only. So there will be sympathetic activity leading to this ischemia. So, and then what happens in the brain? As you all know, the pain is perceived by several areas. That is the network of the brain. That is the pain matrix. That is perceived by thalamus, insula, PAG, RBM, and reticular formation. Now, what happens? As you all know, the brain uses the glucose for their activity because it cannot store. So whenever there is an increased activity of the brain, there will be increased blood flow, and the blood which is leaving the brain will have deoxygenated hemoglobin, and that deoxygenated hemoglobin has different magnetic properties, and that will be picked up by the magnetic, the MRI, that is called the functional MRI. Apart from the functional MRI, the FDG PET and proton spectroscopy, it has been found that there are changes in the brain in these patients. So is there other factors which are responsible? Urinary toxins, genetic factors, and psychological traits all have been implicated for the pathogenesis of this disease. But the most important part is the pelvic floor muscle dysfunction. Whether this is the cause or it is the effect of the ICBPS, that we don't know. So what we are thinking, we should think of beyond the bladder. Don't concentrate only on the bladder. So barring all controversies, the three main mechanisms play a major role for the pathogenesis of ICBPS. First is urothelial dysfunction, second is mast cell activation, and third is neuroinflammation. And we will see that all the therapies which are being practiced nowadays are directed to these three areas only. CNS and PNS sensitization in presence of ongoing inflammation is the main reason for chronicity, and research should focus on these areas. Thank you very much.
Thank you so much, Dr. Uttam. That was a very difficult and lengthy subject, summarized beautifully in a short time span. Thank you so much. I'll request my co-chairperson, Dr. Ratkal, to take over from here, please. Dr. Taneja,
Okay, I'll stop here. Okay.
Slide of the next speaker.
Yeah. Good evening. Hello.
Yes, you are audible, sir.
Am I audible?
Yes, sir. Of course, sir, you are audible.
Yeah. See, now having heard Dr. Uttam Mete and Philip Hanno about nomenclature and pathogenic pathways, now we will go into the Henner's lesion, which is a classical lesion of interstitial cystitis. It has traveled about 100 years. So now Mr. Dr. Dick Jansen from Netherlands will talk on its 100 years journey. It was very clear from Hanno, he made it clearly interstitial cystitis should be given a different recognition as a disease per se, but still it is attached to the bladder pain syndrome because there are some benefits derived from the interstitial cystitis association. So now I will request Mr. Dick Jansen from Netherlands to talk on Henner's lesion journey of century. Thank you, sir.
Thanks for the kind introduction, and I'm really honored to receive this invitation. I will now first start sharing my screen. Hold on for a second. So I hope everyone can view it properly.
Yes, sure.
All right. So I will take you through for the next 12 minutes to take a closer look at Henner's lesion. There's already been lots of nicely overviews by Professor Phil Hanno, and also about the pathophysiology. So I put it more in a clinical context. So this is what we're going to talk about for the next 12 minutes. So first, just simply, we've always spoken quite a lot about it.
But what louder, please? Could you be a little louder, kindly?
Yeah. Can you hear me now better?
Yes, that's better.
All right. So first, basically, I will take you to what are Henner's lesions. Well, I mean, this has been discussed in the previous presentations, but of course, these are just typical inflammatory lesions of the bladder wall. Already discussed, these are really disease-specific type of lesions. So they're really unique to this type of, and I still call Henner's lesions a separate disease, as I really supported the views of taking this out of the BPS-IC group. Causes still unknown. We just saw a nice overview. What we do know, there's inflammatory infiltration and there's a leaky epithelium when you look at it from a bladder perspective. What are the appearances? They're often stellate shaped, often have a central fibrosis core or scarring, and there is vascular anomalies like hyperemia, corkscrew vessels that you see in the right pictures and the below, agglomerations and hemorrhage. And again, because it's now, well, it's 103 years ago that Henner published this. I saw in Hanno's presentation that it was actually 1915. Well, I mean, it's been going a lot of changes over the years. But when you look at it from a pathology point of view, these are just pathology images that I've got from my own samples, from my own patients. There's urothelial dysfunction, fibrosis, and influx of inflammatory cells. And there's a lot of going on pathophysiology about mast cells in bladder pain syndrome. But like Phil also said, there's just not only mast cells. There's a huge amount of inflammatory cell types that will infiltrate the bladder wall. And what you can see here on the right image in the 100 lesion patients, you see that in the below picture, there's really just often a single layer of urothelium left. So that really is explanatory for a leaky epithelial barrier. And what you can also see is these giant cell inflammatory clusters that will develop in the lamina propria region, which are really typical that you see in these 100 lesion type of patients. So also it's been discussed a little bit, so there can be a little bit of overlap, but how should we regard 100 lesions within the whole scope of BPS-IC? Well, Hanno explained this perfectly. The terminology and disease definitions changed over the last century many times, and it was first narrowed, then it broadened, and now we are trying to narrow the definition again or separate them. And that also is in some part also for the Harner's lesion, because it used to be called a Harner's ulcer. Now it's called Harner's lesions. But what we do regard them at this stage is still Harner's lesion patients are currently a subtype of BPS-IC, with the current trend is trying to get it as a separate disease because it has a unique biological, pathophysiological appearance with those Harner's lesions. So, the trend, stratification, subtyping. ESSIC made a clear classification system because there was a real need to, not only for research, but also for clinical management, because there are some, well, access to different types of treatments for 100 lesions patients that are not so suitable for other subtypes. So based on cystoscopy and biopsy, they made a clarification into 3 different subtypes. Type 1 with no bladder abnormalities on cystoscopy, potentially on biopsy. In type 2 was the agglomeration group, which is, well, agglomeration is what we talked about, is not very disease specific, but these would have epithelial dysfunction and inflammatory cell influx into some, well, to some degree in their biopsies. And then type 3, and that's what we're going to talk about, of course, is Harner's lesions. And also the presence of Harner's lesions within the whole group of BPS-IC has been changed very much also because of terminology. It used to be very limited, less than 5%, and it increased to 15%. But currently, there are some evidence that it can be up to 30% of patients that have Harner's lesions. But this can, and of course, can be maybe also be very locally, regionally different between different countries, ethnicities, and so on. We still just don't know about it. In my clinic, I see about 30% with patients with Harner's lesions. So again, BPS-IC is a diagnosis based on exclusion. Of course, all confounding pathologies that can cause pelvic or bladder pain symptoms must be ruled out. And there's the whole list. It's also in the ESSIC side of confusable disease that we must exclude. It seems like a very long list, but majority you can actually exclude very fastly. But still, it can be problematic in times. What you can see here in the figure, it starts with bladder inflammation, and it creates a whole cascade of problems, and it goes from bad to worse, and all the adjacent organs can be affected by this problem, and many of these problems are simultaneously present when treating your bladder pain syndrome patients. So these cascading problems result in pain, it impairs function of different organ systems, it impairs psychological well-being and quality of life. And all these factors are present and contribute to pain and their symptoms, but Harner's lesion is just a small part of this whole. And but again, this presentation is about the Harner's lesion, so I will continue on focusing on the Harner's lesion type of problem, so the local problem. So I think it's really important that bladder inflammatory conditions, BPS-IC or the Harner's lesion patient, is not the only inflammatory condition. You can have chronic radiation-induced cystitis, you get eosinophilic cystitis, cystitis cystica, ketamine-induced cystitis, and others. And of course, there's other confounding diseases that we need to also distinguish between the Hunter lesions and so on. So we have carcinoma in situ, which is really important because that's one you don't want to miss. People with indwelling catheters can have catheter effects. You can have TB in your bladder, which in the Netherlands is very, very rare, but due to BCG treatments for bladder cancer, I've seen them also in the Netherlands. Other areas or in the world where TB is much more prominent, it should be more higher up in your differential diagnosis, that it can also be something else than just plain BPS I see with Hunter lesions. So how does your Hunter lesions as a subtype affect symptoms? Well, the downside is that on average, compared to the entire group of BPS patients, they have worse symptoms. So more pain, more voiding dysfunction, also more things like microscopic hematuria, smaller bladder capacities, also higher chance to become a bladder cripple, so increasing fibrosis leading to a very small bladder capacity and a dysfunctional bladder. There is, at least also in my population, a higher risk in getting other autoimmune diseases like Sjögren, rheumatoid arthritis, SLE, Crohn's disease. But overall, it is less for other comorbidities. Some of the upsides, I already talked a little bit about this, is that it is susceptible to local therapy like endoscopic ablation or coagulation. That really is a good effect on pain and also increases the bladder capacity, even when repeated surgeries and so on. Also, it appears to be more susceptible to immunomodulating therapies like cyclosporine. So then is, of course, what's Hunter lesions affecting and how is it represented in evidence-based medicine, so in our medical trials? Well, although it's really Hunter lesion patients really have a different symptom biological and symptom profile. We already talked about it being considered a unique disease at this moment. Well, most clinical studies for treatments for bladder pain syndrome do not report on the presence of Hunter lesions in their cohorts. Often there's no cystoscopy done in these trials. And if that's reported, then often the percentage of patients with Hunter lesions is very, very low in trials, so that you cannot really assume or make a clear conclusion based on the trial efficacy rates and so on, how it would affect Hunter lesions patients. Also, what to take into account, there are many uncontrolled trials that really disregard the high placebo effect that we really need to take into account. That can be up to 30% in these trials. So if you have an uncontrolled trial and you have an efficacy of 30%, then must regard that also placebo effect can be up to 30% in medical trials for bladder pain syndrome. So how to clinically approach these Hunter lesion patients? So more to the practical sides, performance cystoscopy. You will see it, but you need some awareness. Recognizing Hunter lesions is not that difficult, but you need to be aware of it, that it's be a part of your differential diagnosis. If you're in doubt, do a diagnostic hydrodissensation under anesthesia. You will see a hemorrhage. We saw some nice images from Phil Hanno with a weeping bladder. You can see often mucosal tears becoming more visible. And sometimes you can even spot an occult Hunter lesion, so that without distension, you don't really see that there's or maybe very mild inflammation. And then once you do a hydrodissensation, it becomes much more clear that there is really a local Hunter lesion, which often starts bleeding very severely. Also perform a cold cup biopsy under anesthesia. This really is to rule out carcinoma in situ. And if you do pathological evaluation, I would recommend to use the ESSEC criteria. They put in a nice report on how to pathological evaluate your patients for your biopsies of your patients. So for treatment, I would really recommend endoscopic coagulation and laser ablation. You can do it with a TUR, but I would recommend it to superficially. Compared to each other, the difference doesn't make that much in efficacy, and the risk of bladder damage is much higher when you do a deep TUR. So do it over the Hunter lesions area when possible. Note you can have a pancystitis, which makes coagulation very difficult because you cannot do the whole bladder, you coagulate the whole bladder. But also when there's very large Hunter lesions areas affected, then I would try to do first to try to minimize the Hunter lesions areas by doing some a supportive therapy that improves bladder inflammation. So I try GEC therapy, pentazone as level 1A evidence, but not based only on symptoms and not so much on cystoscopy evaluations. There's a study that still needs to be done. Also lidocaine installations or cyclosporin. These really try to reduce bladder inflammations and can also be supportive with endoscopic coagulation therapies. Other general therapies, which are similar to other BPS-IC subtypes, is just pain and symptom management, amitriptyline, anticholinergics, lifestyle advice, and diet, and so on. And I would recommend to use this or approach this as a multidisciplinary care. So refer to other specialists for comorbidities that sustain complaints. So use your pelvic floor physiotherapist, your rheumatologist, your gynecologist, etc. They can also be helpful in treating the other subsequent or secondary problems that can arise from bladder pain syndrome. And if you treat those comorbidities well, it also boosts more chances of having more success with reducing symptoms in your chronic patients. So I thank you very much for listening. I'm very honored to give you this talk. And because of COVID, I would always recommend everyone not to forget their bladder pain syndrome patients, because at least in the Netherlands, we see a greatly reduction of access to healthcare because of this pandemic. So just be aware of it, that if you neglect your BPS patients, they come back with much, much worse problems afterwards. So thank you.
Thank you, Dr. Dick Johnson. You made it very clear. Hunner's lesion is a disease, can be precisely diagnosed. Can you hear me?
Yes.
Hello? Hello?
Yes, we can.
Can you hear me?
Yes, yes, please go ahead.
See, you made it very clear. It is a disease to be diagnosed precisely and can be treatable compared to bladder pain syndrome. So thank you very much. My next chairman will take over the.
Hello. Yeah, it gives me a great pleasure to introduce young and dynamic Dr. Amit Agarwal. And he is the gold medalist in MBBS, MS, DNB. He is a core member of GIPS. Over 10 years of experience in the field, awarded the Best Reviewer Award of IJU and MJAFI, the member of many scientific societies, Association of Armed Forces Surgeons, USI, UA, ASI, Editorial Board, Indian Journal of Urology, Editorial Committee, Medical Journal of Armed Forces of India. With this, and he has very keen interest in this area of the interstitial cystitis and bladder pain syndrome. With this introduction, may I request Dr. Amit Agarwal to give his talk on the biomarkers clinical application. Dr. Amit Agarwal, please.
Dr. Amit, you need to unmute yourself. Can technical team help? Dr. Amit is not able to unmute himself.
Yes, is it now okay, sir?
Yes, okay.
So, sorry for that. I smile, I try, but the truth is I want to die. This is a common thinking in patients. Sorry, sir, some problem with the screen. I'm not able to advance. I'm not able to advance the slides, sir.
Maybe you can stop sharing and restart.
I'll do that. Not happening, sir. Yes, is there. So this is a common thinking in patients who are depressed and devastated because of interstitial cystitis.
Your screen is not
shared. Share your screen, Amit.
I'm so sorry for this, sir. There's some problem today.
Share your screen.
Have any problem yesterday?
Yesterday was smooth, sir.
On the day of exam, you're having
Again,
problem?
this electronics always is weird. Yes, you change your slide.
Is it okay now, sir?
Yes, okay.
So this is a common thinking in patients who are depressed and devastated because of interstitial cystitis. And in this agony of theirs, they come to us doctors whom they look up as superheroes and expect a quick diagnosis for an early treatment and resolution of the symptoms. But as someone has truly said, an early diagnosis is definitely the key to successful treatment. And as far as interstitial cystitis is concerned, which is a diagnosis of exclusion, the diagnosis may often be delayed, often for years altogether, before we get on to the diagnosis. So today, biomarkers are the new tools in our armamentarium to help us to diagnose this condition early. So let us today look into the clinical application of this condition. So what is biomarker? They are the short form of biological markers. In fact, it is any attribute which can be objectively measured and which tend to indicate the health, the disease, or the outcome of a treatment. It can be chemical moieties, whether in tissues or in biofluids, or physical measurements such as urodynamic parameters or bladder wall thickness, and validated questionnaires, which are the qualitative indices. In this movie, Mr. Amir Khan in 3 Idiots had said that we are surrounded today by machines all around us. So similarly, today, we are also surrounded by biomarkers all around us, be it a physical attribute like pulse and BP monitoring, or the routine lab parameters. But today, we'll be talking about the chemical parameters or chemical biomarkers, which forms the major chunk in our discussion today.
So one sec, sir. So I think other faculties are unmute.
Similarly, today, we are also surrounded by
Tejas bhai, can you please mute the other faculties?
Like pulse and BP monitoring, or the routine lab parameters. But today, we'll be talking about chemical parameters or chemical biomarkers.
It is his own voice which has been recorded and is playing behind.
No, sir. Dr. Ratkar
one sec, sir.
was. So I think other faculties are unmute.
We are also surrounded by. Can we mute everyone from there?
Mute the other faculties.
And BP monitoring, or the routine lab parameters. Today, we'll be talking about.
Amit, you can log off and then again log in.
So now I think it's okay, sir. I'll go ahead.
Yes.
I'll go ahead now, sir.
It's fine. It's fine. Please go ahead.
So before we choose a biomarker, we need to validate these biomarkers and we need to ask few questions. Number one, does the biomarker measure exclusively the clinical condition of interest? Number two, can the biomarker be reliably and consistently measured, and is it sensitive enough to assess the treatment or the progression of the disease? Number three, does the assessment of this biomarker advance the diagnosis or the prognosis of the clinical condition? And number four, is this biomarker affordable, and are there any practical conditions that allow it to be used in our healthcare settings? So in a nutshell, an ideal biomarker would be one which is highly sensitive and specific with a very high positive and a negative predictive value. It is affordable and can be assessed very easily. And also, it should detect the presence of the disease at an early stage. It should point to the causative agent responsible for initializing this pathology and also provide information regarding the intensity of this disorder. And as far as interstitial cystitis is concerned, it is very, very difficult to get one of this because of the uncertain and multiple possible etiologies, the heterogeneous presentations of the patient, and the overlapping disease condition. And hence, the search for an ideal biomarker for interstitial cystitis continues even on date. So these biomarkers can be assessed either in tissues or biofluid. As far as the tissue biomarkers in interstitial cystitis is concerned, they are assessed on the bladder biopsy specimen, and the most assessed ones are mast cells, uroplakins, nerve growth factors, and various proteins. As Dr. Uttam has rightly mentioned about the mast cells, even ESIC identifies mast cell infiltrates of the detrusal muscle as one of the diagnostic criteria. And these mast cells are mostly activated. And it has been seen that the subepithelial mast cell distribution is more pathognomic than the detrusal mastocytus, especially for Hunner's lesions. The uroplakins they help in organizing the apical plaque on the surface of the urothelial cells. And there are 4 subtypes in the humans. The disruption of these uroplakins destroy the integrity of the bladder's urothelial barrier, and the delta 4 subtype of uroplakin 3 has been found to be upregulated in patients with non-ulcerative interstitial cystitis. We all know that there is bladder urothelial defect in patients with interstitial cystitis, which is significantly associated with chronic inflammation. And hence, the levels of bladder and urinary nerve growth factors, various cytokines, and the C-reactive proteins are elevated. The tight junction proteins like zonula occludens 1 and E-cadherin levels are decreased in urine, while there is an abnormal expression of differentiated related proteins and proteoglycan core proteins. As far as the serum biomarkers are concerned, they are mostly the pro-inflammatory cytokines and the chemokines, along with C-reactive protein and the nerve growth factor. The major research is on the urine biofluid for biomarker assessment in interstitial cystitis, and it is said that the latest advances in technology have the potential to make urine a non-surgical biopsy of urinary tract, the so-called liquid biopsy. And because urine is the most easily available sample, and because of its non-invasive collection, and hence it is the most researched biofluid. But a word of caution here, that the increased or decreased levels in the urine may not just be because of the over or underproduction from the bladder, but may also result from the changes to the barrier function of the urothelium. The urinary biomarkers are broadly classified into genomic and proteomic biomarkers. As far as the genomic biomarkers are concerned, they are the areas of intense research, and mostly they are the genes related to the immune and the inflammatory response mechanism. The proteomic biomarkers form the major chunk of the interest in the biomarkers as far as the urine is concerned, and there is a long list of these proteomic biomarkers. The anti-proliferative factor is one of the most promising biomarker, which is detected in higher levels in urine of patients of interstitial cystitis. It decreases the incorporation of thymidine in the urothelial cells and causes an inhibitory effect on the proliferation of these cells. It locks the cell cycle in the G2 and M phase and inhibits the heparin binding epithelial growth factor production, thereby disrupting the normal urothelial proliferation and the repair processes. Their levels decrease after hydrodistension, but no differences were found between the ulcerative and the non-ulcerative form of interstitial cystitis. The nerve growth factor, although not a specific biomarker for interstitial cystitis and is present in several other lower urinary tract conditions, but it correlates very well with the pain scores of the patient, and hence it is used to assess the degree of the bladder impairment and evaluate the treatment response. As far as the glycosaminoglycans are concerned, they keep detaching from the urothelium and are lost in urine, and hence the levels are significantly increased in urines of patients of interstitial cystitis, and they can again be used both for diagnosis and monitoring of the patients of these. The proteoglycans also play a central role in urothelium surface permeability, and GP51 is one of these typical urothelial glycoprotein, which acts as a bacterial defense molecule. And this is found to be produced in lower quantities in patients of interstitial cystitis. The inflammatory chemokine interleukin 8, the CXCL8 levels, along with CXCL1 and CXCL10 also found to be raised, and their levels also decrease after treatment. Another factor, that is the macrophage migration inhibitory factor, which is a soluble factor produced by T lymphocyte, is significantly found to be higher in patients with Hunner lesions as compared to others. Similarly, the levels of histamine and interleukin 6 are also increased, while that of methylhistamine shows no significant difference between the patients and the controls. Nitric oxide although not a protein in itself, is involved in smooth muscle relaxation and a number of other host defense reactions. It has a very short half-life in the biological fluids, but the gaseous phase is stable and it can be easily measured, which can become a non-cystoscopic diagnostic modality for patients with Hunter lesions. TAM hospital-protein, which shows similar levels in urine of patients of ICBPS and normal patients, but there is a qualitative difference in the end glycosylation, indicating an altered protein production. The list is endless. But today, we are a long way from using it as a standalone diagnostic modality. And IC in times to come would remain a diagnosis of exclusion. But biomarkers are still helpful in differentiating from other overlapping conditions, such as overactive bladder. It may also help in detection of Hunter lesions, which is now more commonly found in patients of ICBPS. Also, the detection of Hunter lesions depends on the attention paid at the time of cystoscopy and the training of the urologist to detect one. The various biomarkers which are found to be raised in patients with Hunter lesion, which are nerve growth factor, macrophage migratory inhibition factors, the CD74 receptors, and nitric oxide. The major trust these days about biomarkers is the targeted therapy, because the biomarkers are providing new insights to the underlying pathology, and there is endless possibilities in this route. So as far as the biomarkers are concerned, where do we stand today? The likelihood of finding a single molecule that fits the criteria of a good biomarker in interstitial cystitis is extremely low. However, multi-marker panels, which may be able to encompass the molecular heterogeneity, are likely to be clinically effective. But before we choose one, we need to choose wisely. We need to see whether they are reproducible, whether they make a meaningful result, and whether this testing, whether they improve the healthcare, and whether there's any value addition or cost saving by using of these biomarkers. We know we have a long road ahead of us, but big journeys begin with small steps. And as far as the biomarkers are concerned, we have already taken a giant leap. Thank you.
Thank you, Dr. Amit Agarwal, for updating us about the role of biomarkers. But my one question to you is, in your clinical practice, what is the utility? Are you using any biomarkers or no at present?
So at present, not really, sir. It is more scientific and in more the research area, sir. And as I said, it's not fitting into any diagnostic. We don't have a single diagnostic molecule as far as biomarkers are concerned. It's a multi-panel which may help us in diagnosing and prognosticating the disease.
Actually, my concern is only one: in a country like India, the cost is a very important factor.
Absolutely.
And now, you know, in both in cancer and in other diseases also, there is, plethora of these biomarkers are available. So that increase the cost for the patient, because a lot of, mushrooming of these labs are coming in private sector especially. And it's like a fancy things to have something new diagnosis. They are advising all these kind of tests, which may not be very clinically, useful for us at present. Anyway, but certainly we should know what is the research area, and this will be useful for future. I think that now we have all the 4 lectures are open for any question or comments anyone like to make. Otherwise, all the speakers have done a wonderful job. They have explained everything very clearly. Dr. Philip Hano, you like to give any comments on these lectures?
No, I thought they were very interesting in terms of biomarkers. It's kind of hard to find a biomarker for interstitial cystitis, bladder pain syndrome, as a diagnosis of exclusion. The biomarker isn't really for diagnosis. It has to be more to guide your therapy, because what do you do with someone who has the symptoms and they don't have the biomarker? They still have the disease because it's diagnosed by symptoms. So basically you want a biomarker that's going to influence your therapy and how it works. And that's what everyone is looking for. I thought they were all very interesting lectures.
Dr. Dick, you like to make any comments?
I was, hi. Yeah, I was very impressed by all the presentations. Also, the great overview on pathophysiology and potential mechanisms. I think it goes inside what Phil was already saying. There should be a better connection between pathophysiology and those mechanisms and therapy and outcomes. So I think the goal is just to try with research, try to stratify our patients and create more subgroups that will sort of aim us and guide us in treatment options. And so far, it's in studies it's still lacking. So we just treat the whole group as we speak. Targeted therapy should be the future, but it needs a lot of research. So,
thank you. Co-chairpersons like to make any comments? Otherwise, we'll close this session. Azul, start.
I think we'll proceed, sir.
Okay. So we thank you all the speakers and the chairpersons for cooperating. Now we hand over back to Dr. Rajesh Taneja, please.
Thank you very much, sir, for this wonderful session that you chaired. And now we go on to the next session, and I invite the chairpersons. The first one is Dr. Rajiv Sood, a dear friend who is the Dean Postgraduate Medical Institute at an RML hospital near Delhi. He is the founder core member of GIBS, has over 37 years of experience on the subject, and is an awardee of the prestigious Dr. B.C. Rai Award in 2017. Our next panelist, chairperson, is Dr. Shailesh Shah. He's a senior consultant of repute in reconstructive urology and transplant surgery, and is the senior consultant at Bodyline Hospital, Ahmedabad, India. And the third chairperson is an associate professor and head of Government Medical College and Hospital, Chandigarh, India, Dr. Vidur Bhalla. I welcome you all to chair the session. Please take charge and introduce the speaker. Dr. Rajiv Sood, Dr. Bhalla.
Okay, good evening, everybody. Now we start the proceedings of this important session, and our first speaker is Dr. Apul Goel, who is Professor, Department of Urology, King George Medical University, Lucknow, and founder core member of GIBS. He is associate editor of Indian Journal of Urology, and also he has been awarded with the Dr. T.P. Banerjee Symposium. He has a Duskon Award and many other laurels are there. I'll now request Dr. Apul Goel to start the proceedings of this session, and he will be talking on cystoscopy in BPS, that is the controversies. Dr. Apul Goel, please.
Thank you, sir, for the introduction. Thank you, Urological Society of India and Dr. Rajesh Taneja for inviting me to participate in this webinar. I'll be discussing cystoscopy in ICBPS, the controversies. So if you see the ICBPS literature, the term cystoscopy has been used ambiguously and loosely. If you see, cystoscopy is used as cystoscopy alone, cystoscopy with bladder hydrodistension, cystoscopy with bladder biopsy, or it might include all of the above. So what is the possible relevance of cystoscopy in the scenario of ICBPS? if you see the ESSEC guidelines, which mention about confusable diseases, the diagnosis of ICBPS is a diagnosis of exclusion. So for excluding other confusable diseases, there is a role of cystoscopy. For classifying IC with or without Hunner lesion, for bladder biopsy and further classifying ICBPS, or cystoscopy is also used as a therapeutic modality in the form of hydrodistension, triamcinolone injections, or other treatments in the form of fulguration or resection. And we'll be discussing the controversy with all these issues that I am in this slide, mentioned in the slide. So why is cystoscopy considered controversial? The biggest issue with ICBPS is that there's no universally accepted method for diagnosing this condition, and it remains a diagnosis of exclusion. So each physician, each treating physician has their own perception or their institutional guidelines regarding the protocol that has to be followed to exclude other conditions. Most confusable diseases can be ruled out by taking a history physical examination and a urine analysis. However, certain conditions might still merit a cystoscopy. So here there's ambiguity. Some physicians will like to do a cystoscopy while others may not. So another issue is whether IC and BPS are two distinct entities. Here, by saying IC, I mean patients with Hunner lesion, and BPS are those patients without a Hunner lesion. So the controversy is whether the presence of Hunner lesion a hallmark of a distinct disease cohort, or whether Hunner lesion are transient feature of non-Hunner lesion phenotype. So this controversy is always there. So another bigger confusion is that the clinical differentiation between these two entities is almost, clinically it is almost impossible. There are n number of papers that have tried to look into clinical parameters by which they can differentiate Hunner disease with non-Hunner lesion disease, and they mention that it is difficult to distinguish classic IC from non-Hunner lesion BPS, and they recommend cystoscopy with local anesthesia for patients diagnosed with IC-BPS. And this paper comes from Curtis Nickel group. So they recommend doing cystoscopy under local anesthesia to differentiate between these two entities. Another paper that comes from USA, they also mention that standard clinical evaluation cannot reliably distinguish between Hunner and non-Hunner disease. And these findings suggest that cystoscopy is needed to accurately identify patients with Hunner's ulcer, they mention, or Hunner lesions. Another reason for controversy regarding cystoscopy is that if you see the AUA guidelines, cystoscopy is mentioned both in the diagnostic and the therapeutic algorithm. So if you believe this, if you follow this, this guideline, you need to do cystoscopy twice, once as a diagnostic modality in patients who have complicated ICBPS, and then in another later on as a third line treatment where you do cystoscopy under anesthesia with or without hydrodistension. So that means you subject the patient to cystoscopy twice. So often what happens in usual clinical practice, a physician might like to combine the two procedures, do a diagnostic as well as a therapeutic procedure at the same go, again creating confusion in the treatment protocol. So the confusion lies, as I have mentioned, that ICBPS is a clinical diagnosis, and even today, no guideline requires cystoscopic or histopathological findings for definition or diagnosis. Even the ESSEC advocates cystoscopy and biopsy, even in their definition, there's no the cystoscopic or histopathological findings are not mentioned. Also, even if we believe that we like to do a cystoscopy, then also there are no accepted diagnostic cystoscopic features for this condition. Hunner lesion, which are considered hallmark, are a very rare finding, and they are very difficult to find, difficult to locate. And another finding that is often mentioned in this ICBPS literature about glomerulations, they are neither specific nor sensitive for diagnostic purposes. So we are, even if we like to do cystoscopy, actually the pickup rate is very, very less. So if you see the AUA guidelines in patients who have uncomplicated ICBPS, they do not recommend cystoscopy. It's only after the basic assessment in the form of history, voiding the chart and all that, you can start first line treatment. However, if you see the ESSEC guideline, they clearly mention that in patients in whom you are clinically suspecting ICBPS, you need to exclude confusable diseases, and they are very, very clear that you need to do cystoscopy and biopsy and then further classify patients according to cystoscopy and biopsy findings that you get. You further classify and then you give treatment. If you talk about another guideline, which is the East Asian guidelines, they give more liberty to the treating physician, and after basic evaluation and what they call as a hypersensitive bladder, you can either go in this direction and do a cystoscopy with or without hydrodistension, or you can start conservative treatment, and if the patient doesn't improve, then you can go in for cystoscopy. So another issue is cystoscopy with hydrodistension. The initial paper that I mentioned about the Nicol Curtis paper, that they do cystoscopy under local anesthesia, and often it is a office-based flexible cystoscopy where they are looking for Hunner lesion or a patient, differentiating between a Hunner patient and a non-Hunner patient. So cystoscopy with hydrodistension is recommended in the ESSEC guideline because it is part of the procedure for cystoscopic evaluation, and also to do a biopsy. So they recommend hydrodistension, and as I mentioned initially, it might also be therapeutic. So EAU guidelines, they follow the ESSEC criteria. So of course they recommend subtyping of patients that require hydrodistension and biopsy. The East Asian guidelines that I mentioned, they also support the EAU recommendation, which is essentially the same as the ESSEC criteria. However, the AUA and other guidelines suggest hydrodistension is optional as a diagnostic test because of conflicting evidence regarding its utility. And another guideline, the RCOG, does not recommend hydrodistension. Now, coming to bladder biopsy. So ESSEC, again, because in the initial slide I had shown that ESSEC, basically they recommend doing a biopsy, and this also helps in phenotyping patients. Now, the number of biopsies and from where they have to be taken is again controversial. Some people take only single biopsies. Some authorities recommend up to 3 biopsies. It can be from the lateral wall, from the dome, from the trigone. And of course, you need to take a separate biopsy from any abnormal looking lesion. Now, the positive findings, if you see, are fairly non-specific in the form of inflammatory infiltrates, granulation tissue, detrusor mastocytosis, and intrafascicular fibrosis. So many of these histopathological findings are sort of non-specific. So if you see the EAU guidelines, biopsies are essential for establishing or supporting the clinical diagnosis of both classic and non-lesion types of disease, which is basically the ESSEC guideline. And other guidelines state that none of these features, the ones that I mentioned in my previous slide, are diagnostic. They are non-specific findings. So AUA biopsy is only indicated to exclude other pathologies and not form part of routine diagnostic process. This is the AUA recommendation. The East Asian guidelines, they mention that biopsy is optional, and other guidelines they do not recommend. So again, this is controversial. To summarize whatever I have mentioned in my previous slides, this chart clearly shows that cystoscopy, diagnostic, hydrodistension, and bladder biopsy, if you see the EAU guidelines, all are recommended. If you, in the AUA, none are recommended. And you see a sign here, which means that it is optional. So other guidelines, some of these things are optional or not recommended. Now, even when you do a biopsy, you do a cystoscopy as part of the initial evaluation, ESSEC, what they have done on the basis of cystoscopic findings and the biopsy findings, they have subclassified all the patients into various categories, 1X, 1A, 1B, 1C, and all that. Similarly, the East Asian guidelines, as I had shown, they also mention biopsy as an optional procedure. However, again, there's no unanimity in the sub-classification, the ESSEC and the East Asian. If you see the BPS type 1, here there's unanimity, but in the type 2 and the type 3, there's again no unanimity. The Hunner lesion is negative and here it is positive. And so again, there's controversy in the sub-classification. Now, there are other controversies, for example, the type of anesthesia that you use for cystoscopy. Of course, if you are planning an office cystoscopy, it can be done under local anesthesia. And in fact, the chapter in the Campbell's Urology also mentions that you do it under local anesthesia. But I think the issue would be that then you subject your patients to cystoscopy twice in case the patient needs a third line treatment as mentioned in the AUA guidelines. So typically hydrodistension is advised. All guidelines, they mention that it has to be done under some form of regional or general anesthesia. But again, there are papers where people have used hydrodistension under local anesthesia. Our Gibbs guideline, they mention that it has to be done under some form of anesthesia, either local, either general anesthesia or regional anesthesia. Then there are other controversies as regards cystoscopy, how much pressure, how much volume to be infused, how many cycles, which type of anesthesia, and practically each body has their own guidelines. In Gibbs, we have our own guidelines which have been submitted for publication in an international journal. Now, cystoscopy of late, there's some technological advances in the form of narrow band imaging. As of today, not much literature has come up in the field of ICBPS, but as these technologies will gain more foothold in daily practice, I think they will be, in future, they'll be source of controversy in this field. Thank you so much.
Thank you, Dr. Apul Goel, for this elaborate discussion on role of cystoscopy and all the controversies you have touched. And it is true that cystoscopy becomes the integral part in our setup in many urologist clinics because of India being a tropical country and so many, it may be tuberculosis, maybe CIS and other problems are there. So it is really controversial. Maybe in the guideline, note guideline, individualized management of the patient becomes important. And whatever we are suspecting, we proceed accordingly. So with this, Dr. Salesha is there. Dr. Shailesh,
unmute yourself.
I am there.
Yeah,
yes,
please
yes.
invite Dr. Rajesh Taneja. Oh, sorry. There is
Good evening, everybody. I think Dr. Rajesh Taneja is speaking, no, according to the original program, or the slide is for Dr. Mauro.
So, Sailesh, you go ahead and introduce Dr. Mauro so that he can proceed with his presentation.
Okay. Happy to present Dr. Mauro Servigni, who is the Vice President of ESSEC. He is a urogynecologist from Italy. He is specialized in both urology and gynecology. And today, he will be talking about intravesical treatment status of new agents. Dr. Mauro, please.
Thank you all.
Yes, please.
About the treatment for status of me. Can you hear me?
It's interrupted, sir.
Hello? Hello? Okay.
Dr. Moro, if you
These are my
stop
disclosures.
your video, probably the internet connection will be able to transmit the sound better, probably.
Can you hear me now?
Yes. Yeah, your screen sharing has started.
Okay.
Okay. Please go ahead.
This is the AUI. Okay, this is the AUI guideline in which you see the second line treatments is related to the intravesical treatment for BPS-IC. If we look at the ICI guidelines, the last one in 2017, the intravesical treatment is related to the first line treatment. So there is a difference in terms of approach between ICI and AUA. If we look at the intravesical substances, we can have cocktails of lidocaine, triamcinolone, zentamicin or heparin, DMSO, PPS liquid, BCG, racine ferratoxin, oxybutynin or GAG replenishment. But more recently has been cancelled as an option for treatment 3 of those substances, and also some question about the liquid pentosan polysulfate. Certainly the more common use of intravesical treatment is the DMSO, the dimethyl sulfoxide, with a grade of recommendation B with the level 2 of evidence, with several actions. None of them are completely clear, but is the more long-term use as a therapeutic agent for BPS. It has significant small side effects as the garlic-like odor, the cataracts and bladder compliance, as well as retinal maculopathy, more recently in long-term users. These are some reported data from DMSO with improving, for instance, from the peaker experience on frequency and pain in ulcer type IC patient, or Perez Marrero in 88 with a 93 response in objective evaluation, or also an overall of 80% improvement according to several authors. The lidocaine is another intravesical treatment with very small success, 30% verum versus 9.6 placebo effects. And also the more recent proposal of intravesical device to release the lidocaine 24 hours a day, even though with the preliminary experience, more recently has been withdrawn from the market because there is no consistent effect. If we add also alkalize heparin and lidocaine, we have assisted to fourth installation, 60% rated effective, but after 6 months follow-up, only 16.7%. So if you look, the only one can be really effective is a DMSO with quite 70% of response, and also has been evaluated in a randomized clinical trial, and lidocaine no randomized clinical trial with 65% success. As you know, one of the causes and the etiology of the PPS-IC is the dysfunctional bladder epithelium, because the GAG layer represents the effective barrier in the urothelium layer against the entrance of irritating solutes or the potassium ion into the bladder wall. And there are 6 classes of GAG: the chondroitin, dermatan, keratan, heparin, and hyaluronan. And the 2 more important are the hyaluronan and the chondroitin, because they are localized mainly in the extracellular matrix of loose connective tissue and are most abundant on GAG. Looking at the etiology of BPS-IC, one of the first step is the epithelial layer damage, and one of the effects of the GAG replenishment therapy is to recover the epithelial layer damage, but also interfering with the potassium leaking into the interstitium, the activation of C fiber and substance P, or release the activation of mast cell with histamine. This is a recent paper about the hyaluronic acid that decrease interleukins 6 and 8 suppression and permeability in inflammatory model of IC BPS. And you can see at your left the GAG layer protecting the urothelium, the damaged urothelium, and the proposed mechanism of GAG replacement therapy on recovery of the GAG layer. So the proposed mechanism would be 1, increasing the secretion of GAG enzymes with the GAG secretion; 2, the direct physicochemical interaction with the decreased permeability; and 3rd, the decreasing secretion of cytokines with the decreasing inflammation. So the hyaluronic acid can significantly decrease induced cytokine secretion with increased sulfated GAG production, and without altering tight junction expression, decrease transepithelial permeability. This is very important for such kind of patient. If we look at the current EAU guidelines, you see that the hyaluronic acid and chondroitin is a grade of recommendation B. And according to the guidelines, it is well documented that intravesical instillation are a valuable and beneficial therapy. These are some data reported from the literature about the GAG substitution layer therapy, and a patient of response that sometimes is not very good. If we look at the level of evidence and grade of recommendation, the hyaluronic and chondroitin, they have for the EAU, the 2B, both of the substances, while the ICI is a 1D, 1C, or 4D, or 1C. If we look at the efficacy of chondroitin at week 7, 22 of placebo patients were responders compared to with 39 of Verum group, and so the results are not very good. And also the unpublished data of the company, the BioNiche, on under 37 patients, 8 weekly instillation, 61 success versus 80% of placebo. So there was a really very astonishing results. In 2013, there was a review published on Neurourology and Urodynamic, in which the large pharmaceutical trial of hyaluronic 40 milligram and 200 milligram failed to show efficacy, and also the chondroitin sulfate failed large phase 2 efficacy trial. So the conclusion was it's urgent to have a new randomized clinical trial to define specifically the role of GAG replenishment therapy. We recently published a review article on neurourology, urodynamics, evaluating the beneficial effects of intravesical GAG replenishment therapy for providing symptomatic relief for patients with BPS. we started the experience in more than 10 years ago with a combined solution of hyaluronic and chondroitin sulfate for refractory BPS. But I would like to emphasize and to see that this new combined substance contain, you see, 800 milligrams of hyaluronic, that is 20 times more than the common substance present on the market with 1 gram of chondroitin sulfate. Probably this is the difference compared to the other substances. And there was the secondary, the tolerability and the side effects. Small group of 23, but was a refractory patient, and the symptoms and problem index was significant, as well the visual analog scale, the frequency urgency questionnaire. The conclusion that was at that time that preliminary experience promising further study are necessary. And we did a long term on 3 years, and again demonstrated a real great real reliability after 3 years. And the conclusion was the improvement in symptoms still apparent at 3 years follow-up. After this preliminary but very productive experience, we evaluating, these are the data presented on the literature with a combination of hyaluronic and chondroitin sulfate, proposed and evaluated in a different prospective study as a pilot study, but including also, for instance, different also radiating cystitis and so on. And this is, we published more recently a randomized open label phase 3 multicenter study on the efficacy and safety of hyaluronic and chondroitin versus DMSO. Why? Because DMSO was the substance with the highest grade of recommendation among the available intravesical treatments. This is the reason. The only problem was the impossibility to mask the difference between DMSO and Hyaluril for the garlic-like odors. This is one of the limit of the RCT. But we compare 60 patients in the Hyaluril arm versus 30 in the DMSO, considering to have 80% of probability to highlight the desired difference at 6 months. The primary objective was the efficacy, and secondary objective was efficacy and other parameters of bladder function, tolerability, quality of life, and economic consideration. The endpoint was 3 months and 6 months, and about the pain reduction superior for hyaluronic and chondroitin, as well as the symptom questionnaire, significant reduction from baseline measured for hyaluronic and chondroitin compared to DMSO, and also the voiding diary, significant improvement. Again, the quality of life, significant improvement measured for hyaluronic and chondroitin. And this is a very impressive data about the safety results, the adverse event. You can see that hyaluronic, only one adverse event compared to the DMSO, 12 adverse event with a highly statistical difference. And also the difference in terms of the pain reduction with a significant difference between the disease stage. That means that if you treat the patient in an early phase, you can see you have a reduction of 45 reduction at 6 months in the first observation, and less 26 reduction with unresponsive to first line non-invasive treatment. That means early you treat the patient, more success you can have. this is the clinical observation, early treatment of the disease, greater clinical and statistical advantage. So in conclusion, pain reduction greater with hyaluronic and chondroitin, more experience of visual analog scale reduction with Aluril, more than 50%, and the chance of becoming a responder with Aluril was higher than DMSO of 26% at the end of treatment. So the final consideration, and it was that as clinician, we must realize that BPS-IC is not a disease of the bladder, but is a clinical syndrome with features of urgency, frequency, and pain, to the development of a neuropathology that results in a visceral pain syndrome. And when we abandon the organ-based concept of BPS-IC and instead accept the neuropathic or visceral pain model, we can realize the benefit of multimodal therapy. This is important to take on mind, because the GAG replenishment therapy, it's important, but could be and should be subscribed according to other pharmacological treatment on the patient. Thank you.
Hello.
Thank you, Dr.
Thank you, Dr. Mauro.
This is a complete insight. Dr. Saleh. Okay, so with this, continue, Dr. Salesh.
Yeah, okay, Sud sir. Thank you, Dr. Mauro. It was a wonderful discussion about intravesical treatment, and we will have a questions later on. Now I invite our today's convener, who has designed this program. Dr. Rajesh Taneja is not only a big urologist, but he takes care of the smaller subject also. I had an happy occasion to take part with him for chronic perineal pain syndrome symposium. Similarly, in India, for the interstitial cystitis group, he has done a lot of hard work, and I think he will be talking about ablation of Hunner lesions. What are the current recommendations? Rajesh Taneja, please.
Thank you very much, Dr. Salesh. But I will just take a minute to start my presentation, because I don't know where it has suddenly disappeared, my presentation. Yeah, this is here. So just give me a minute. Yeah, so that I can you please tell me if you can see the screen? Can you see the screen, please?
Yes, sir, it's visible.
Okay. So without wasting much time, I'm going to talk about the ablative techniques of Hunner's lesions. So Hunner lesion that we have been talking about in the last 1.5 hours is classically described as a circumscribed reddened mucosal area with radiating vessels. They are parallel radiating vessels with a central pale scar with some fibrin-like deposit or coagulum. This is a typical description of Hunner's lesion. And as a surgeon, whenever we find a lesion, we try to resect. But does ablation of Hunner lesion really work? So Guy Hunner, who described this in 1915, described an open resection of Hunner's lesion resulting in relief of pain in such patients. And then as the techniques and technology advanced, by the year 1971, transurethral resection of Hunner's lesion was established by Walter Kerr and was published in 1971 Journal of Urology. And it was postulated and advocated by Magnus Wall and Norling et al. That removal of intramural nerve endings and the inflammatory aggregates, as Dick Jansen showed in the histology slides, is perhaps important because it cuts the pain inflammation pain cycle. As you remember what Uttam Mete talked about, a reverse neuropathic inflammation. So pain causes inflammation and inflammation causes pain. So that is how resection of or ablation of Hunner's lesion works. So ablation of Hunner's lesion can be done by resection, as in transurethral resection like we do in a prostate case, or electroablation with a ball electrode, Bugby electrode, or two types of lasers. I'm going to talk about them in the subsequent slides. So Magnus Fall in 1985 established clearly the advantage of resection over coagulation. At that time, it was thought that the cutting current is superior to coagulation current because it was thought that the coagulative current could promote fibrosis and contracture of bladder. In addition, careful radical electroresection, including the perilesional edematous areas, would result in a better advantage in terms of relief of pain to these patients. And by the year 2000, his group, led by Peeker, who published the case of 219 TUR lesions, TUR of Hunner's ulcers, at that time described as ulcers, and they were performed over 103 patients. 92 out of these 103 patients had a very good response. 40% of these patients had a long-lasting response, more than 3 years. And in the remaining, where the response was not as long-lasting, their symptoms which recurred responded very well to subsequent TURs. So they concluded that it has a good outcome in patients with classical interstitial cystitis with Hunner's lesion, and suggests this as the first-line treatment of this group of patients. Then in United States, there was some concern about resection because it was thought that there would be chances of perforation and leakage from the bladder. So they started talking about electroablation, which gained prominence and was included in the recommendation of AUA in 2014. And they tend to talk about the fact that the efficacy of resection was as good as the efficacy of electrocoagulation, and the risk of perforation and serious complications was evidently less. So these are the three studies quoted by the AUA guideline paper. And if you look at it, they have the two of these series have a large follow-up of more than 20 months, and they did not report any adverse event, while a smaller study with a shorter duration reported one minor perforation treated with Foley, which means electrofulgration can also lead to perforation. The reason is that these bladders, they are not normal bladders, and they are scarred, they are thinned out, and if you try to coagulate and the current passes through, and if they happen to crack, there is the blood supply is less. As a result, there is less healing and less strength in the tissues. So this is the study which was published in May 2020, and they talked about a single center retrospective randomized controlled trial involving 126 patients with Hunner's lesion, and they found that there was no difference in the recurrence-free time and the effect of return of urinary symptoms, including pain, whether you do a resection or coagulation. So there were no contraction of bladder after repeated treatments, as initially it was advocated by Magnus Fall. And this was published by a study done by this group from Japan in the Arab Journal of Urology in the year 2018. Fulgration with Bugby electrode. You see, when you are scared about the perforation and other things, some people have tried fulgurating with Bugby electrode, but there is no scientific data available. It appears to be doing a superficial ablation only, and probably is less efficacious than the ball electrode, which has a deeper penetration than the Bugby electrode. And then the YAG, the ND YAG laser, was first used by Schonberg in 1985. It is a 15 to 30 watt setting with a pulse duration, with a pulse depth of 5 millimeter, and it causes a rise in temperature between 60 to 70 degrees centigrade. And they advocated that it leaves behind the elastic tissue undamaged. They only hit at the scarred or the diseased tissue, and that is how they just leave the bladder there without causing fibrosis or scarring. There is no doubt a theoretical risk of forward scatter of the laser through the bladder wall, which may present as delayed damage to the bowel, but this has not been reported in these series. It is difficult to control the depth of penetration, as the bladder wall thickness may vary not only from the perspective of a given point of time, but also vary from one place to another, and at one point of distension to another point of distension. They had a mean follow-up of 10 to 23 months. 80 to 100% had a relief of pain. Up to 46% required retreatments during this period. And that is how, based on this paper, AUA has included this as a part of recommendation for ablation of Henner's lesion. Holmium laser ablation of Henner's lesion was attempted by Andrew Zikev from Moscow. And I followed, and this is my video, and this is recorded in 2008. And it is a pulse laser with a depth of penetration of 0.4 millimeter. It is a superficial penetration. And then the immediate efficacy seemed to be good, but I realized that there was a early recurrence of pain and other symptoms. So I have given up doing a holmium laser ablation of Henner's lesion. So coming to the intralesional injection of triamcinolone, since the Henner's lesion appeared to be an end stage of an inflammatory pathology, consequent to this thought, it was very logical to use a steroid if it could be injected locally, like we do in dermatology. So Cox et al. Published their paper in 2009, and they used a total of 10 ml of 40 milligram per ml, which amounted to a huge dose of 400 milligram of triamcinolone in a single sitting. And they recommended using intralesional and around the lesion and the suburothelium using a cystoscopic needle. They found that 70% of patients had immediate relief, and the duration was response was almost a year. However, it has been found and later recommended by AUA that the total dose of triamcinolone should not be exceeded in a given sitting beyond 60 milligram for the fear of its disseminated side effects in terms of the dose related. So Christine Whitmore and her group published a paper of the retrospective study of 100 patients, and they injected a combination of triamcinolone and local anesthetic, and they injected 10 milligram triamcinolone per lesion, and they put a limit of 200 milligram per patient in a single sitting. It was a retrospective study, and at 3 months, there was improvement in pain frequency in nocturia. However, they still exceeded the AUA recommendation of 60 milligram total dose. So there is a paper in the BMC Urology published in 2020 May, which talked about a paper from China, and they said there is no adverse effect even if you used triamcinolone 400 milligram in a single patient in a single sitting. And this is a paper that has come up recently, but then we need to know in the long term what is the effect of such a high dose of a steroid given in a very short period of time. So this is just a slide as to conclude how do I do it in case I find a Henner's lesion. So I start with the general anesthesia with a rigid scope 20 French 30 degrees with the glycine because I use a standard cautery. And once the irrigant is sufficient to inspect the interior of the bladder, which is usually around 100 or 150 ml, we stop the irrigant, inspect the bladder thoroughly, make the note of all the findings. And then once we have made up our mind where all the lesions or not lesions or whatever lesions they are there, we make a note and then distend the bladder with a drip chamber method described by Nordling, where you wait till the drip chamber stops dripping, and the height of the reservoir of the water, the glycine, is 80 centimeters from the pubic symphysis. So we look for the mucosal cracks and cracking of the center of the Horner's lesion. If it is there, we deflate and measure the quantity of the irrigant coming out and notice any bleeding of the bladder mucosa. This is the time to take a biopsy. And this is a video. You can see the real-time video where this is a Horner's lesion in the bladder, which is otherwise a normal looking bladder. So this is how you identify. And there's another one. So they can be kissing, they can be attached with each other through the kind of tentacles. And I ablate Horner's lesion after taking a biopsy with the ball electrode. And after having distended, you see, once you distend, this is how it appears. It gets totally parched. That is why I emphasize about the use of cystoscopic technique using using a low pressure. So we need to have a diagnosis. We need to have a diagnostic cystoscopy at a low pressure, and then you distend, because the Horner's lesion may get stretched and missed. And this is the decompression thing that you can see. While it is being decompressed, it bleeds only at the Horner's lesion, and rest of the bladder is fine. We put a 3-way catheter, connect with the saline irrigation at 80 drops for 2 hours, and then stop. Thank you very much.
Thank you, Dr. Rajesh Taneja, for this lucid talk and very descriptive explanations about how you, in the history, we had been going through the ablations of Horner ulcers wherever they are identified, and also the updating us on the procedures, various energy sources used, and also your techniques, which is really very impressive. And the way you have described, all the delegates are going to be benefited. Now I'll request Dr. Vidur Bhalla to carry the session further, and to invite Dr. Shivam Priyadarshi for the final talk of this session. Dr. Vidur Bhalla, please. Dr. Vidur?
He needs to unmute.
Unmute his voice. Vidur, you need to unmute your laptop. You have to speak a little louder. We can barely.
Am I audible now, sir?
Now, yes, of course you are audible now.
Fine. Fine. Thank you very much, sir. It is a pleasure to invite Dr. Shivam Priyadarshi. He is a professor at the prestigious SMS College at Jaipur. He is a founder core member of GIVE. He has served North Zone chapter of USA as secretary. He has 24 years of experience in the subject. He is a member of many prestigious societies, and today he will be talking on a logarithm for the management of IC and VPS.
Thank you, Dr. Vidur. Respected chairpersons, faculty members, and viewers, a very good evening to all of you. So I have a humble duty of summarizing the whole thing as the last speaker into an algorithmic approach. So at the outset, I thank USI and ISU for giving me this opportunity. So I believe that ICBPS is a disease of extremes. Patient may have extremely severe symptoms. It still remains extremely underdiagnosed, and the treatment may vary from one extreme to the other, ranging from alpha vitamin prescription to omega of radical bladder surgery. And sadly, there is extreme confusion still about the etiopathogenesis and the management of ICBPS. Still, it remains a challenge to diagnose ICBPS because The symptoms are quite confusing with other disorders, and the patients usually have to visit multiple doctors with years of suffering and sometimes undergoing unnecessary surgeries. And at the top of it, still there is a lack of objective investigation which can clinch the diagnosis. So most of these patients would present as refractory to various treatments that they are undergoing, maybe for recurrent urinary tract infection, for overactive bladder, for failed endometriosis, or even in male patients for prostatitis. So this poor patient is in a state of fix or dilemma when the doctor tells him that your examination is normal, you have normal investigation, but the patient himself is very miserable. So whenever such a patient comes, the most important part is the symptom complex that he presents with, which would be a pain, which could be in the form of a pressure sensation or a discomfort also, which is perceived to be arising from the bladder. And usually this pain is maximum when the bladder is full, and usually it is relieved when the patient voids, and it's accompanied with urgency or frequency or nocturia. Sometimes it may be associated with other disorders like fibromyalgia, allergies, migraine, chronic fatigue syndrome, etc. The patient can have a history of sexual dysfunction, and there could be a history of drug intake which can produce similar symptoms. The physical examination is usually unremarkable in these patients. There may be a suprapubic tenderness, or it could be an anterior vaginal wall tenderness in the bladder neck region in females. And in males, there could be a tender prostate on rectal examination if it is prostatitis. A voiding diary or a frequency volume chart is often very helpful in these patients because they produce classically the small voided volumes, which could range from 17 to 25 times per day. And it also determines the severity of the storage symptoms. Amongst investigation, we have urine in the form of a dipstick test or a routine microscopic examination. And at GIPS, we feel that ultrasound, which is an extension of physical examination, should be done in these patients, which may rule out other confusable disorders. So amongst a differential diagnosis, besides urinary tract infection, endometriosis, where the pain is worse during menstrual cycle, non-infectious cystitis, where there is a history of radiation or chemotherapy or non-steroidal anti-inflammatory drug intake, a vulvar disorder where the pain usually occurs during voiding when the urine comes in contact with the inflamed vulva. An overactive bladder where the patient usually voids to avoid incontinence rather than to relieve pain, as it happens in ICBPS. A pudendal neuralgia where the pain is worse in the sitting posture, and a prostatitis where there could be a painful ejaculation or a tender prostate on examination. So all these can be differentiated by additional testing, where we can do a urine culture to rule out UTI, an AFB culture for genitourinary tuberculosis, urine cytology if there is microscopic hematuria or it is a chronic smoker patient, serum PSA if the patient is a male patient above 50 years of age, an anesthetic challenge test, laparoscopy or imaging study to rule out pelvic pathology, particularly endometriosis, and a uroflowmetry or urodynamic study to rule out bladder outlet obstruction or voiding dysfunction. An intravesical anesthetic bladder challenge test often can be helpful, and it will confirm the pathology in the bladder and the pain emanating from that. So we can instill 10 to 20 milliliter of a mixture of lidocaine and sodium bicarbonate for 10 to 15 minutes, and this will not only help to relieve the patient of pain, but also can provide diagnostic information. And in this respect, we have a very important study which was done by our own Dr. Rajesh Taneja and was published in 2010 in the International Journal, which is often cited as a reference in these cases. Cystoscopy, though it is not essential for diagnosis of ICBPS, but because it could be normal in many of these patients, but it definitely helps to identify the Hunner's lesion, which reflects a very severe variety of disease. And it also helps to evaluate the functional bladder capacity and also rules out other bladder lesions. Bladder biopsy is usually not recommended because histopathology usually shows a non-specific chronic inflammation. The management would extend from a conservative behavioral therapy to surgery. The conservative management would include patient education, counseling, stress management, behavioral therapy, physiotherapy, various kinds of analgesics, sex counseling, and the dietary modification in the form of restriction of coffee, tea, chocolate, beverages, citrus juices, and spicy food. Yoga, which includes various asanas and the breathing and the relaxation techniques, can definitely help to release the tension of the pelvic floor muscles and also reduce the stress which is related with this condition, thus improving the overall quality of life of the individuals. Amongst oral therapy, the commonest drug used is amitriptyline, which is started with 10 milligram dose, and others include analgesics, antihistaminics like hydroxyzine, anti-inflammatory agents, anticholinergics, and in neuralgic pain, we also use gabapentin. Cimetidine is also used, and in some cases, resistant cases, we use cyclosporine also. Pentosan polysulfate, we know, is the only US FDA approved drug, though it doesn't help in every patient, but in a select group of patients, it could be of help. Intravesical agents, we know it's already been discussed, and there are various agents which can be helpful. The other therapies would include sacral neuromodulation, cyclosporine, and intradetrusor Botox injection. And the last resort is the surgery, which is done in the form of bladder augmentation or a cystectomy with urinary diversion. So, as an algorithmic approach, when a patient comes with pain, which could be a discomfort or pressure sensation perceived to be arising from the bladder with frequency, urgency, nocturia, then we should always keep in our mind the entity of ICBPS. And all these patients, particularly if they are middle-aged females, they should be subjected to history, physical examination, voiding diary, urine routine examination, and ultrasound. And all these would differentiate these patients into two groups mainly. One is an uncomplicated, unequivocal ICBPS patient, and the other could be a complicated equivocal ICBPS, where the other confusable disorders should be ruled out by other investigations. Like if there is pyuria, you need to do a urine culture. If it is sterile pyuria, then you need to do an AFB culture to rule out geotuberculosis. If there is hematuria, you do urine cytology. If you are suspecting endometriosis, you do laparoscopy. And if you are suspecting voiding dysfunction, you do uroflowmetry or urodynamic study. If it is a case of uncomplicated ICBPS, because these patients are often suffering for long duration and have had multiple treatments, we feel that cystoscopy should be done in the beginning only, because cystoscopy would help us to differentiate Hunner's ICBPS from non-Hunner's ICBPS. And as Hanu has already said, these are probably two different distinct entities, and they have a different natural history. They have a different progress of the disease with different treatment options and different prognosis. So if there is a Hunner's IC, then we need to do hydrodistinction with fulguration or resection as described by Dr. Taneja, and we could also inject triamcinolone. And in follow-up of these patients and monitoring, we continue with the conservative therapy and pharmacotherapy along with intravesical installation and pain management. If these therapies fail, then we can try neuromodulation, Botox, or cyclosporine therapy. And ultimately, if all these fail, then we need to resort to surgery in the form of augmentation or cystectomy. So if these patients, it's a non-Hunner BPS, then often it is associated with other pathologies like fibromyalgia, allergies, IBS, migraine, chronic fatigue syndrome, etc. And the further treatment will be based on symptom phenotype and the degree of quality of life impairment, the patient's preference, the availability of the treatment, and the adverse event profile. And all these patients should be properly educated, given dietary modification and sex counseling. So according to the phenotype, if that is we call as U-point phenotyping, if there is a urinary symptom which is predominant, then we need to do bladder training, anticholinergics, or intravesical agents. If there are psychosocial issues which are predominating, then we need to stress on management of stress and psychosocial support, and sometimes yoga and meditation can be helpful. If it is organ specific, where there is more symptoms related to bladder pain, then treatment would be amitriptyline, pentosan polysulfate, intravesical instillations, Botox. There are patients who have precipitation of symptoms due to recurrent infections. In these cases, short courses of antimicrobials might help. If there is a neuralgic pain, then gabapentin, hydroxyzone, and neuromodulation might help. And on physical examination, if you find there is tenderness in the pelvic floor muscle, then physiotherapy, massage, or acupuncture, or even trigger point injections would help in these patients. So the basic principles of clinical management is the treatments are ordered from most to least conservative. Multiple simultaneous treatments may be considered if it is in the best interest of the patient, and ineffective treatment should be stopped. Pain management should be considered throughout the course of therapy with the goal of maximizing function, minimizing pain and side effects. And diagnosis should be reconsidered if no improvement within clinically meaningful time frame occurs. There are various emergent therapies also, which includes hyperbaric oxygen, N-acetylcysteine, monoclonal antibodies, cannabinoids, intravesical liposomes, edilmidrol, tacrolimus, magnetic stimulation, adalimumab, and Botox even in levator muscle. So the take-home message is ICBPS is a symptom complex diagnosed by ruling out other confusable disorders. It has a wide range of presentation and management must be individualized. The future approach lies in a better understanding of the etiology of the various phenotypes as well as the discovery and validation of biomarkers. It is a chronic disease which requires a long-term healthcare plan. And lastly, as clinicians, we must be very proactive in diagnosing and mitigating the suffering of these patients because there are millions of people who are suffering and very few who really understand them. Thank you.
Okay. Thank you, Dr. Shivam. It was a very lucid talk. And you have rightly mentioned that it is extremely underdiagnosed. And there are challenges of diagnosis. And most of the investigations are to rule out the other things. And then you have highlighted the total algorithm and also highlighted the latest medicines. So similarly, other speakers, Dr. Appal talked about very nicely about the cystoscopy and diagnostic and therapeutic approaches. And he gave all the guidelines. It was a very lucid talk. Dr. Taneja, of course, as usual, is always wonderful. His videos were excellent. And his otherwise overall contribution is immense. Then Dr. Mauro also talked very well and intercycle treatments, the latest updates. All the speakers have talked very well. Now I'll request Dr. Rajiv Sood to give his comments, please.
Thank you, Dr. Vidur, and you have very well summarized the gist of all the 4 talks. And I'll say that the last slide of Dr. Shivam was really interesting, that millions suffer where very few understand. And that is true for all the treating physicians also. And we are still in the phase of learning.
Hello.
More and more with such discussions. Dr. Shailesh wants to make a comment. Yes, Dr. Shailesh.
Yeah. I have a question to Dr. Mauro. He suggested DMSO, chondroitin, hyaluronic acid intravesically. He did not speak about Botox. I would like to know from him what is the #1 choice for a particular patient for him. Is he around or he has left?
No, he's there. He's there. He will listen.
Yes, thanks for your question. I didn't speak about Botox just because I intend about the title of the presentation only the intravesical, not the the trusorial or submucosal injection. This is a different one. But if you want to know, which is my opinion, I have no particularly enthusiasm for the Botox. Obviously, in some very selected cases, could be proposed to the patient, but according to the data, the recurrence is quite the normal. And after 8 to 10 months, there is a recurrence of the pain and the other irritative symptoms. And moreover, there is also a side effects about the UTI that is sometimes is very bother symptoms on those complex patients. So it could be a third or a fourth option for the patient, but is certainly is not a treatment of choice. More recently, has been proposed the liposome with the Botox, associated with the Botox, introduced as a gel into the bladder as a installation. That could be a promising because there is only outpatient procedure, but obviously we need to wait the long-term data and also in a more broader group of patients.
Thank you. Thank you very much.
Thank you, Dr. Morrow. And this is important also in the Botox, which we do here, that in the trigonal area also we are injecting, otherwise we are not injecting Botox in the trigonal area. And the injection frequency gradually increase, the timing gap increase, and the sustainability of the effect that keeps on improving with the injections. This is in the limited experience we have experienced, but yes, Dr. Morrow has very clearly advocated that Botox is not the preferred choice. We can take more questions, but there is a problem of delay already of 20 minutes. We are running late, and next is the panel discussion, and therefore I'll hand over back the proceeding to Dr. Rajesh Taneja, because in the panel discussion we will be covering most of the things which are left. Dr. Rajesh Taneja, please.
Yeah, thank you very much, Dr. Sood, Dr. Vidur, and Dr. Shailesh for such a wonderful conducting the session. And now we go on to the next part, and that is case-based panel discussion. It will be moderated by Dr. Sanjay Pandey, who needs no introduction. So you find him in all the specialties of urology that you have, starting from the embryology to reconstructive to robotics and general reassignment to transplant. So Dr. Sanjay Pandey, he is a dear friend. He is a secretary of Global Interstitial Cystitis Bladder Pain Society, which we co-founded in 2016 in Mumbai. And he has had advanced training in so many places. Without wasting time, I will invite Dr. Sanjay Pandey to take charge of the panel discussion and invite his panelists. Dr. Sanjay, over to you.
Good evening.
Dr. Sanjay Pandey.
Yeah, good evening. Can you hear me?
Yes, yes, we can hear.
Yeah, so would you take away your slide for me to share screen? Yeah, good evening.
Hello.
Dr. Taneja,
Yeah,
you
yeah.
need to take away.
Hello. Yes.
Dr. Taneja,
Yes.
your
Hello.
slide.
Yeah. So no, you have to introduce the speakers, no?
Yeah, so I have my own slides. So I've got the speakers around. So you can
So
take
I
away.
will. Okay. I'll stop
Yeah,
sharing.
yeah. See, stop sharing. I'll finish it off. I am keeping it very crisp. Good evening, everybody. We heard the stalwarts, and we're moving forward with. Just give me a second. We will. That's it. For the paucity of time, we have made some changes, and we will see how to take it forward. Okay, there we are. So good evening, everybody. We're keeping it very crisp. All those who are in the panel are the leaders in the subject who have not spoken till now. We heard the stalwarts on the panel discussion in the Saturday School of Urology. Women will lead the front, and when we have women who already lead the front on this subject, we have Dr. Amita Jain, senior consultant urogynecologist at the Medanta Hospital in Gurugram in India. Dr. Amita, thank you so much. Are you around? Are you unmuted?
Yes, sir, I'm here.
Yeah, please stay unmuted. All the panelists, please. Thank you so much for being there. Dr. Anita Patel, senior consultant urologist at the Global Hospital, Mumbai. Dr. Anita, are you around?
Yes, of course I am.
So nice. Good evening to you. Dr. Navita Purohit, consultant in the rehab medicine as a physiatrist, and I'm working with her at the Kokilam Ambani Hospital. She takes care of the pain therapy of all the ICBPS cases out there. Dr. Navita, are you unmuted and you here? Navita, are you around?
Yeah, I'm there.
Okay.
Can you hear me?
It cannot happen without a teamwork, and therefore we have men who lead the show. And we have our guest from Budapest, Hungary, urologist at the Rosgart Medical Center with 4 decades of work. I met him at the ESSEC in Rome, Dr. Sandoz Lovas. Thank you so much for being there. I've seen you being there for the last 2.5 hours listening to the deliberations of our colleagues. Thank you for being there. Dr. Lovas, are you unmuted and are you around?
Oh, I'm here and hello. Good
so
afternoon.
Nice. Good to see you. Good afternoon to you too. Dr. Sanjay Sinha, honorary professor and consultant urologist at the Apollo Hospital in Hyderabad. Good evening, Dr. Sanjay. Are you around?
Of course.
So nice. And a doyen in the subject, who's led the subject from the very front, Dr. Nagendra Mishra, senior consultant urologist in the country at the Sri Krishna Hospital and Pramukh Swami Medical College in Anand in Gujarat. Sir, you are around. Good evening to you.
Yes, I'm there.
So nice.
I could make it.
So nice. Thank you so much. You could make it this time. We are happy to have all of you here. I would like you to raise your hands. I may miss out everybody, but we go forward with the challenge and the burden that seems bigger, with the subject being thrown over A to Z in the last 2 hours. Case 1. We have got 2 cases. We'll attempt to finish it in time. We'll keep answers very crisp. I'm thinking to look at if I can see everybody. Else you can interject and even answer. So we go that. 41 years female who has got discomfort in the suprapubic region. She complains of burning pain in the introitus. She has got intermittent exacerbations of the above symptoms for the last 2 years. And she also has increased frequency of urination. She was treated for an episode of UTI recently 4 months ago in the lockdown. She has got regular menstrual periods. And when she came recently, she carried an ultrasound report which was normal. Her urine routine shows few pus cells and a urine culture was sterile. Dr. Lovas, welcome to India. Welcome to the show. Welcome to Saturday School of Medicine. What are your thoughts on this young lady?
There are a few questions which I would like to be get answered.
Yeah.
What is the capacity of the maximal capacity of the bladder?
We only have this to start with. So you have any questions for the patient, you would ask across the table. And yes, if you're asking me, I would answer it to you in the next slide. So keep talking.
Okay. And then also, how frequently is worsening the symptoms? Is it a regular worsening, or irregular? If regular, is it in connection with the period in any way? So first, this would be my questions.
Thank you. That's bang on. So what questions would help us to move forward? And there were these important questions which actually came in. Dr. Anita, if you would like, if I could come to you on this very thing, and you want to add any more questions that he was asking?
Yes, Sanjay, I would add that is there day and night frequency, or is it more during her waking hours?
Yeah.
Does she have any bowel symptoms, and does she have any history suggestive of sexual dysfunction? And that is as far as the history goes. I presume her obstetric history was normal, and that's probably not contributory. So these are the main things that I would like to ask on the first visit of.
Wonderful.
Can I add something, Sanjay?
Sanjay, Dr. Sanjay, sir, please.
Yeah. So, hi, good evening, everybody. So a couple of questions I would ask is, one is what's driving that frequency? And the other is, does she have incontinence? Because these would give me a clue to the diagnosis, in addition to obviously what other things.
Great. Dr. Nagendra, sir, you want to add any point to all?
Yes. I would like to know about this bladder discomfort's relation with the bladder. So does the bladder discomfort increase with voiding, and when she passes urine, the bladder discomfort decreases? And number two, when she gets a desire to pass urine, she has to go, or she can hold it for some time so that she can forget it for some time and then pass it. So relationship of the pain with the full bladder and voiding and urgency.
Wonderful. I think I've got all I wanted. I'll just move forward and sum up to what you all have asked about. The duration of discomfort in months and years, her exacerbating factors, as rightly asked by Dr. Anita, and the relieving factors, the UTI episode in details, its importance to the whole situation that has only one episode. The gross frequency is both day and night. The night is more about getting up with discomfort and pain, other lower tract symptoms, and what are the baseline lower tract symptoms. We'll just move forward and give you some facts in her case. Discomfort since the last 23 months, which is 2 years after her second delivery. It is exacerbated by coitus, and she avoids that. This is more significant overall in her symptom complex over the past 4 months after the episode of UTI. She has learned a frequency of urination, which is more of a forced frequency. And to answer Dr. Nagendra, sir, yes, she has got a discomfort, and therefore she is forced to go to the washroom, and therefore she has a forced urgency frequency. She also lives her life on her own in this lockdown, where she relieves herself with soda bicarb, cetal, self-medications off the counter, and she avoids very specific food, which also is a part and parcel of her lifestyle, which is actually worsening over the last n number of years. Dr. Amita Jain, if you're around, could you just add to something and look at what is she going through? What does it look like when these facts are presented to you in the backdrop of all that has been told?
Yes, sir. So I can see that there are symptoms related to two pelvic organs. If we start with, so she's having some symptoms to her urinary tract, that is, she's having discomfort, and her frequency is because of that discomfort, fear of getting worsening of discomfort rather than fear of getting leakage of urine. So that is one fact. But other fact, I can see that she had a bad history of her second delivery. I would like to take a detailed history, whether there was a kind of tear or something, which, because she is giving a particular history of a kind of dyspareunia and a kind of pain at vulva. I can see in your first slide. So there is a kind of, we can see vulvodynia, and we have to examine, is there any ongoing infection or something? We have to rule out the causes for that particular pain at the, could be a kind of chronic condition. It could be something infection which is going on.
Yeah, should be okay. Dr. Navita Purohit, can I come to you? Imagine this lady in her very first activity, and she comes around as discomfort, burning pain, introital region, deep down there, some kind of dyspareunia. I'm just changing slides for you to go through her real facts. And then she has got a discomfort all through in the lower abdomen. Dr. Navita, I just heard Dr. Mauro Savigny speak that loud and clear that this is a visceral complex where bladder may not always be the cause, but they have got bladder symptoms, and therefore we ascribe it to the bladder, which is a new wake up and awakening on the entire subject. Navita, what does it look like if the patient sees you after she sees me in the outpatient department?
So for me, I would like to further add to the history that what is the character of the pain, because I need to know the pain generator.
Can you be louder, Navita?
Can you hear me now?
Yes, better. Go ahead.
Yeah. So it's not only the visceral, but I have to see whether it's a neuropathic, because it's a burning type of pain. So there is certainly a neuropathic component involved with it. And what exactly is the character of the pain, because the history itself will let me know what should be the pharmacotherapy I would start for, because when you are dealing with the diagnosis, then I need to know the pain generator and start her for some basic pain management. So, and also an important thing over here, because it's been 2 years, what is her mood when she talks to me? So that I would like to get more addition from all these things. And we'll go to the examination later.
We'll come to that. We'll come to that. Yeah, we'll come to that. Dr. Nagendra says, Nagendra says she avoids specific food. What does it mean to us?
So, that food might be causing her increase in the pain. That's why she avoids. So she might be, in a way, allergic to that food.
Okay, yeah, good. So we move forward. We've heard a lot on this so nicely, actually. I will miss out if you raise your hands because you need to interject directly and talk over. I'm not able to see everybody in one go. So we come to examination. Dr. Navita, you wanted an examination. So I would look at the examination and the expectations in examination. Because of the burning pain, the discomfort in the perineum, somewhere Dr. Amita Jain did talk about a tear or incision out there. So I'll come to you, Dr. Amita. This is a female patient, young, 2 years, 2.5 years after a second delivery. She has all this discomfort and she has given up her sexual activity. A question very thoroughly asked on genitourinary, sexual and gastrointestinal part by Dr. Anita, which did ask her. So tell me a little bit about this. Do we need to rule out all this in a woman, Dr. Amita Jain?
Yes, actually the examination is the most important thing to differentiate between these different kind of differential diagnosis. So obviously just looking at the external genitalia, if there is an inflammation, redness or something is there, then probably the diagnosis of vestibulitis could be raised, and then we have to find out the cause. And we can do some kind of investigation as well. We have to rule out sometimes herpes as well. Sometimes we have just need to know how she's taking care of her local parts. Sometimes these patients, because of the pain or discomfort, they are actually cleaning their local parts very regularly with water, and they are not keeping it dry. So these are the things which can cause vestibulitis, and we have to rule out any active infection as well. Then we have to examine, for the vulvodynia and vestibulitis, you can see that vulvodynia is particularly pain once you are touching her vulva. So she will squeeze her vulva, that is at the entrance of her vagina. It won't be deep, but it will be causing superficial dyspareunia to the patient. While vaginismus is the spasm of her pelvic floor muscles. So once you will touch inside, probably you can see that her pelvic floor muscles are quite squeezed. She's squeezing, she's complaining of tenderness. You can see the muscular bands or sometimes some trigger points as well. So in this way you can differentiate. And of course, for the bladder pain syndrome, you particularly find tenderness limited to the once you are pressing over the anterior fornix, anterovaginal wall, then probably if the tenderness is particularly there, then you can suspect that some pathology could be inside bladder.
Got it. Thanks, Dr. Amita. That was actually opening the Pandora's box on examination, which many a times, as urologists, we may miss out.
Sanjay, may I add something?
Yes, please.
Yeah, so in addition to what Dr. Amita has already mentioned, even in a female patient, when the symptoms are so broad, we should always try and do a rectal exam also. So it's not selectively kept reserved for a male patient, but even in a female patient, because if it is particularly tender for her, and if the anal sphincter is very, very tight, then my diagnosis becomes broader and goes more towards, non-relaxing pelvic floor with pain, so on and so forth. So that's just the addition.
Yes, that's terrific. Thank you so much,
And
Anita.
I think these patients will also give history of chronic constipation or pain during defecation as well. Sometimes they are.
Yes, yes. So that's fine.
Can I add something, Sanjay?
Yes, Dr. Sanjay and then Dr. Nagendra. Dr. Sanjay, sir.
Yeah, one diagnosis which is often difficult to make and gets missed and can account for many of these symptoms is the presence of a urethral diverticulum with intermittent inflammation happening. So I think in the physical exam, we have to be very careful to exclude a urethral diverticulum, which might not be very obvious on a cursory exam.
Awesome. That's fine. Friends, you actually listening to, we don't want to miss out other aspects, other organic or diseases while we are working towards a discomfort level to treat her. Dr. Nagendra, sir, your final comments on this?
Sanjay, I will just do a per abdomen examination in this patient and will, because PV examination and per rectal examinations are very painful. So at the first initial exam, I will not examine her from vaginally or rectally. We'll only do PV exam, we'll only do per abdomen examination.
Okay, so there are different ways to look at, in different ways people work on. I agree to all of them because as we move forward, we look at various aspects of this. The clinical examination we have already talked about. I will leave this alone and move forward. So what working diagnosis comes to mind to plan further? Because she is in agony. Dr. Navita, before we come to this very important slide, you heard about this clinical examination, which we will take up on the rectum, on the abdomen, on the vagina. Navita Purohit, you want to add something towards the therapeutic aspect of the examination?
So while we are doing that, so we have to, I would do all three. I would go for PV, PR, and for abdominal and look for the tenderness. And here, even there's we have to see whether there are any myofascial bands, because when we do a vaginal examination, so as Dr. Vaginismus we have spoken about, vulvodynia we have spoken about, but then we see the spasm of the pelvic floor, we can actually feel some taut bands or myofascial bands, which are called as myofascial bands, which is very common in maybe because all these things can lead to the visceral can lead to muscular spasm, and then even we have to look for suprapubic muscles, how they are, and there's a test in which we can differentiate between the two, whether it's a visceral or a muscle. So when we tell the patient to lift both the legs along with the neck, and if the pain, and then touch on the abdomen, if the pain increases, then it is a visceral, and if the pain doesn't increase, then we are looking at the muscle. So this can identify that we are looking at a visceral problem or a purely muscular problem.
Got it, Navita. Got it.
Yeah.
That's good.
So
That's good.
Definitely go for this. Yeah.
Good enough. So it could be various ways, but to me, this myofascial bands was always Latin and Greek till I read Campbell's Urology latest edition, which actually not talks in details about what are myofascial bands on examination, pelvic, and probably our students in the audience would pick it up and move forward. Dr. Loaz, can I come to you? What does it look like from all that our colleagues have evaluated today in this lady? What would be your working diagnosis or differential diagnosis, or we are pointing towards Dr. Loaz?
I would add some diagnostic steps. First, also the challenge test could come into consideration, but we would rather do a special urinary diary. We developed a special way of looking at the diaries. It means the 2 days diary, where the patient should have concentrated urine on the first day and a very diluted urine on the second day. And we measure the portions, the average portions on the first day and the average portions on the second day. In healthy people, it's proven by healthy volunteers that there is no difference between the portions having concentrated urine and diluted urine, whereas if there is a ganglion insufficiency, then the first day, the concentrated urine irritates the bladder so much that the capacity reduces. Difference between the 2 days grows. And the bigger the difference is, the worse condition of the ganglion is. So we can first prove that there is a ganglion insufficiency, and second, we can quantify if it's just a slight induction phase or a serious ganglion insufficiency.
Okay, thank you. Thank you, sir. I've got it. We have got leaders in functional urology in our country, Dr. Lovaz, and the two tallest leaders, Dr. Sanjay Sinha and Dr. Anita Patel, are out here helping us solve this important aspect. So we're looking at all this, and many of these patients go through the misdiagnosis, and probably we miss it out. As Dr. Rajiv Sood did talk about that, many a times they are washed away by looking at aspects which are missed out. And obviously our gynecology colleagues who see more than us do pick up aspects of this. So could it be an overactive bladder? Could be a recurrent UTI, could be chronic pelvic pain syndrome and spasms, could be endometriosis, and aspects which could be missed out. I'm moving forward on that, ask questions of what we would do in evaluation for the paucity of time. And to evaluate the voiding diary for 3 days, some urine routine cultures, she had a day and night frequency. Dr. Anita, you had asked about this, was 14 in the morning, daytime, and twice at night. Night, she would get up at discomfort and not with the comfort levels that I and you get up. Her urine routine pH was 6.0, pus cells 3 to 5, RBCs occasional, and urine culture sterile when she came out of the lockdown. Ultrasound abdomen pelvis done in a fasting with bladder full showed a full bladder and a residual volume of 40 ml. So that was a nutshell of the evaluation, which was very close to what was her past, except that flare up around. Except that even after she has given up her food habits and given up all that which could be part and parcel of exacerbation, she continues to still go to washroom 14 times. She continues to have the agony in the introitus pelvis discomfort and has given up everything because of dyspareunia. Her past evaluation was similar to what has been done till now. Empirically, she was treated with all that. So what next that she continues to be having all these stable symptoms but continued agony? Dr. Sanjay, how do we take her forward?
So I mean, the key would be rule out organic problems, and you've done most of the things that we need, but obviously at some stage I may escalate her imaging to make sure that we are not missing other things, not just the ultrasound scan. Rule out functional problems. You've told us she's got a low PVR, but I might be more careful in asking a history about her voiding, and if necessary, just do a non-invasive flow test to make sure that that's okay. So if all the rest of the evaluation is consistent, and she tells that she's symptomatic on the day when you did the urine examination, and the urine exam was normal. So that tells me that there's no urinary tract infection causing the symptom because she's having symptoms and the urine exam is normal. So she needs to be symptomatic on that day. So if all this is in place, then I think we have a reasonable working diagnosis of a bladder pain syndrome based on what we have told us. There are remote possibilities based on what you have said, which could suggest otherwise, but I'd say that's a reasonable working diagnosis.
Yeah, so we are actually moving in that direction. Dr. Anita, you want to add anything here at this point with Dr. Sanjay?
The only thing I would add is the only urine report we have shows microscopic hematuria, and we know that many patients with a bladder issue in IC would have some RBCs, and I would just like to double check that. That's about it. It doesn't necessarily mean, so I would do one more urine exam. As far as sonography is concerned, I always like to know the pre-void volume and not just the PVR of 40, because that adds immense value, and I'm sure Sanjay meant to say that. And the third thing is, I do want to know on voiding diary, not just the number of times she is voiding, but I do want to know the volume. And also in that, if she could add whether she had pain each of the time that she passed urine. And the good thing in the information so far is the night frequency of only twice. So I'm a little relieved because it's not going to be a disaster, because many patients of bladder pain syndrome, in fact, pass urine 5, 6, 7 times at night because their functional capacity is so low, and they are a particularly difficult group. So all these are the only additional things, but otherwise I would go with what Sanjay just mentioned, that treat her like any other BPS.
Good, got it. That's amazing. That's very good. If I just move forward for organizers and for the audience, give us 10 more minutes that the speakers have actually cleared their throat and are really moving on to help this lady. We have one other very short case. So just give us some time, please. Dr. Nagendra, you're raising your hand. I cannot see you. Yeah. Dr. Nagendra, have you raised your hand, sir?
Yes.
Yeah, go ahead, sir. Make it a short comment.
So I will see, I am more or less sure that this patient has got bladder pain syndrome, and I will straight away do cystoscopy under spinal anesthesia.
Okay. So, sir, the cystoscopy is on. This is an unedited video. that it looked like to everybody that this is an unedited video completely. Anybody could speak on the video, but it's all about this lady who can, Dr. Anita can hold a bladder capacity of anything in the voiding diary, 250 to 270 ml is what was her functional bladder capacity. Dr. Amita Jain, are you around? Could you look at this?
I can see the Hanner's ulcer, which was typically defined on right lateral wall. And again, this is our second one. So we can see the radiating vessels and the bleached area in between. And apart from that, the bladder mucosa of otherwise looks quite normal right now. I think you are hydrodistending the bladder, and we have to see for any glomerations to develop later on. This is the Hanner's ulcer, which was first seen. And
so Dr. Amita,
capacity seems to
Dr. Amita, you said the bladder mucosa looked normal to you. Have a look at it.
Now I can see the cracking of the mucosa. It is with more bladder filling. You can see that is typical of a small capacity bladder, which is very common in these patients. And that was on the anterior wall, sir. Otherwise, I cannot see any glomerations till this time. Now it is also started. So now we can see the pinpoint hemorrhages, which is typical glomerulations, but it is not very diagnostic of this disease, but it can be there with any small capacity bladder, with a functional small capacity, because once you are distending it beyond that, then it start bleeding. So I can see, and mucosal tears are more obvious now, sir.
As I said, Dr. Amita, this is a very unedited video, never shown before. We're just opening it for the first time. I edited it today afternoon. The mucosa is not normal, and it's just cracking up in initial cursory look on a cystoscopy in that real-time speed.
Can we have, I don't know, sir, have you gone to see those Hanner's ulcers again? What is the status?
So this is a cystoscopy done very recently. It's a cystoscopy done where the recording is directly from it's not the best of the recordings directly recorded on the iPhone, but you can see what is happening here. Dr. Amita, I will let you have a cup of coffee. I'll get Dr. Anita here on any other things that she wants to add on this cystoscopy.
Yeah, before we talk about just this scopy appearance, my question to you, Sanjay, do you always do a scopy under a spinal anesthesia for somebody with this kind of symptom complex? And I would also appreciate comments from other panelists if I'm not taking too much of time.
No, this is important. Comment. This is important. So I always do under general anesthesia, because apart from identifying everything, we may land up with the procedure called cystoscopy and proceed, which could be biopsies, which could be fulgurations, which could be all that. So spinal, not necessarily. I mean, it's a general anesthesia.
Yeah, it's just curiosity. So what we tend to do is we do it provided the patient allows, because these people find urethral manipulation extremely painful. But if they do allow, what we do is keep them under a very light sedation with anesthetist standby, do it under a local, so that when the patient is awake, you can actually see the awake capacity, and then you can, compare your findings under a proper anesthesia. It's just a point of technique. As regards this cystoscopy, I agree with every point that Amita has raised, and I don't think I have anything new to add. The question is, are we going to biopsy this particular lesion? We are seeing at least 3 or 4 lesions. They were scattered on both the lateral walls and also on the anterior wall and on the fundus, as I could see, because it was pretty close to the fundic air bubble. And should we be biopsying these lesions? And has this patient, since she's under your care, has she been counseled about the possibility of simultaneous cystodistension? Because the question in my mind always is, if I do a nice deep through and through biopsy, should I be distending the bladder under the same anesthesia? There is always that little apprehension, because some of these bladders are a little thinned out, and if you do a very overzealous biopsy, that can be an issue. So that's the only thing that I would add. But any ulcer in patient with this symptom configuration, I would err on the side of biopsying. That's all.
Completely. We did hear Dr. Taneja's techniques, and we did hear colleagues talk about that she is under a kind of care where in the institute we do everything under general anesthesia, because it's a cystoscopy and proceed. And I gather there are many ways to bell the cat. Nobody allows us under a local anesthesia and a standby. so that we could actually get into all the aspects which have not been picked up till we became invasive. But I gather that this patient is counseled enough to look at a fulguration and a biopsy. We live in a country where microscopic hematuria could also be genitourinary tuberculosis more commonly than ICBPS, which could be landing up overdiagnosed. So that could be something of a very, very important phenomenon. Give me a second to Dr. Sanjay, you are adding something.
Yeah, I just wanted to make a small point. Please. Now, the odds of finding a Hannah's ulcer in your patient is at best about 20% or so. That means that if you do a cystoscopy at this point in the patient's care, you will end up doing a cystoscopy and potentially a hydrodistension in a patient who has not been subjected to any of the initial conservative managements. And the odds of that happening would be 80% by the given stats that we have right now for Hannah's ulcers. Although I have a suspicion even that 20% is possibly an overestimate. So I would not ordinarily be doing a cystoscopy at this point. That's all I would like to say. I mean, clearly at some point, I would, but not at this point.
Sanjay, I will just like to add.
So I'll come to you, Nagendra sir, I'll come to you. So Dr. Sanjay, do you want to say, or is it a way that we could continue, or we could now get into management activity and wait for the cystoscopy to be taken a little later?
No, so what I mean to say is, if you look at where cystoscopy is positioned in our management algorithm, it does not come before conservative management with conservative therapies, physical therapies, medical management, and so on. We have not yet done any of those things in this patient. So and since this is a cystoscopy, if at all it's done, is ideally done under at least some form of anesthesia, anesthetist standby, so that you can actually do a proper cystoscopy. Biopsy, if required, is usually a cup biopsy in these patients. But you want to be prepared for everything, so you need to do it under anesthesia. So clearly, if I do, either I do a cystoscopy, don't find a Hannah ulcer, and don't do anything and come out, in which case I think I've done a disservice to the patient, or I now do go ahead and do a hydrodistension, discuss with the patient upfront, obviously, in which case I have given invasive therapies before giving non-invasive therapies. So I would not ordinarily do a cystoscopy at this position in the algorithm.
Getting it. So there is an important school of thought and tiers of management, even by the AUA guidelines, that you get into a therapy, get into counseling and a confidence building, managing the patient, looking at changes happening completely. That arm is absolutely great. Dr. Mishra, your point before I move on.
Yes. I will always do under spinal anesthesia. I will always take biopsy and do hydrodistension. And because I'm not sure whether I will get a Henner's lesion or not, I may take more time. So I will like to fulgurate this. And Sanjay, the type of patients I get and the type of patient Sanjay Pandey gets, I have around 35% patients with Henner's lesion in my series. And even Sanjay must be seeing the same number of patients.
So you would still jump the gun on 65%?
35%.
No, you would still jump the gun on 65% by doing a hydrodistension even before you've given them the first medical management.
Yes, I will do hydrodistension in all the patients because that gives immediate relief. And I tell you frankly, even the Gibbs did not have cystoscopy as the first investigation. They added it. And even American Urology Association will add it in 2-3 years. Believe me, if you do cystoscopy at the first go, patient will get immediate relief. She's already suffering from 2 years. So how much more time do you want her to suffer?
So we got it. So
Sanjay, may I?
Particular in this patient, will you do the biopsy in this patient?
Yes.
Because on initial entry into the bladder, it was just the Hannah's ulcer, nothing else. So whether you are going to do the biopsy in this patient?
Yes, Amita, all such patients, around 10% of red lesions in bladder will have significant pathology. So because this lesion developed while we were distending it, it's a pre-distension lesion, we have to do biopsy. And I tell you,
Dr. Nagendra sir, I will, that's fine. I have heard views around. I'm happy about listening to all views because finally at the end of it, the patient is getting treated by all of us. Dr. Loaz, you wanted to add a point before I move on?
I would like to add my point. In this case, first, I would have done cytology, urine cytology, just to exclude carcinoma in situ. And
good one. Yeah.
I performed the cystoscopy and just a low cystoscopy because Hannah lesions in most cases can be seen already at the low pressure cystoscopy. And there were also some signs in this case. For example, there were many spiral vessels visible, which is also a sign, or can be a sign, of interstitial cystitis. So in this case, I would have performed first conservative treatment, maybe even local intravesical treatment. And if the patient doesn't improve, then I perform a high pressure cystoscopy in general anesthesia, and then I can coagulate it.
Perfectly fine. Dr. Anita, I missed you. Dr. Anita, go ahead with your point you're making. There's only a video running, don't worry.
No, not at all. I just felt that it's good to disagree, and that is what this forum is for. So I'm somewhere in agreement with what Sanjay Sinha said, that we've offered nothing to her. We've jumped to scopy, and maybe that is because she had microscopic hematuria. So let's not discuss that further, but otherwise, all these patients are worthy of maximum possible non-invasive therapy, unless that is leading us nowhere. Coming back to this cystoscopy, now again, this is a second video that you are showing, and these lesions don't really look very nice to me, to put it in simple terms. And since I am doing it under an anesthesia, once I see lesions like this, the first thing I would do is decompression under anesthesia. And a typical Hunner's ulcer or the glomerulations will always bleed, you know, when you're decompressing such a bladder, whereas the ulcers which are, say, due to some other inflammatory pathology or something like carcinoma in situ, during decompression, such bladders are not going to bleed, but those are distinctive mucosal lesions which are 100% worthy of a biopsy. So I would again err on the side of biopsying, more so the lesions look like what you're showing now. Because what we want is not just to prove that it's BPS, but we also want to prove that it's not something else. So that's all.
Not to miss out something. I'm getting it. I mean, there's a great sentence you said. It's always nice to agree to disagree and beyond. I'm moving forward to this important aspect now. So Sanjay, we start with you regarding, just give us a little lead on this very case that we heard the stalwart speak over slides. A quick management on her, that we stabilize her and give her back her life.
Right. So I think several things would need to happen in that first counseling session. Number one, a reassurance that the problem is unlikely to be life-threatening or serious. Number two, getting realistic treatment goals established. That, you know, we are not trying to, we can't promise a miracle, and the first goal is to make sure that she can carry on with life. Then giving her initial symptomatic pain relief, along with whatever medicines we use. So use of pain medication along with pain response modifiers and amitriptyline and drugs like that. So I would, and since she's got a frequency urgency, most such patients, at least to begin with, I would also add overactive bladder therapy medications. So I would put her on an initial conservative management, reassurance, and pain management, and counseling is very important with these patients. And of course, if there are any pain trigger points which the physiotherapist has found, then those need to be addressed.
Completely fine. Friends, at this point in time, I will just play 4 slides for everybody. Please be ears and eyes as I go forward. Look at these 4 slides. We're just moving from ladies first to now men. 4 quick slides. 2016, he was 54 years young. He had progressive lower tract symptoms, burning micturition, gross frequency, in fact, also forced frequency, which his history talks. At day and night, he was 15 times in day and 8 times at night. And as Dr. Anita would ask, her volumes were anything between 150 to 175 in every of these voids. Most of them were with discomfort. Therefore, he had learned his ways of finding his ways to the washroom as forced frequency. He had, with urologist in the city where he came from, failed combination therapy of alpha blockers and anticholinergics, as would be given to somebody with that severe degree of LUTS. His life was worsening at that point in time, 2016, when American president was being chosen. He was evaluated outside and treated for all these above at that point in time. 2016 moved to 2017, and I looked at the treatment charts which we had carried. He was then 55 years young. He had a uroflowmetry of a baseline straining pattern, which you can close your eyes and imagine as to what he must be avoiding. His cystoscopy under local anesthesia by a colleague urologist in the city did pick up a grade 1 prostate, steep bladder neck, bladder of adequate capacity with no erythema, no growth, and no calculi. It continued symptoms and difficulty, underwent a TURP and a BNI as a chosen aspect of treatment that there was nothing else being effective. And he was too symptomatic and hypersensitive. And therefore, possibly with the uroflowmetry and a cystoscopy, good enough for that team which took him forward and treated him. He continued to have symptoms of cross urgency, precipitancy, urge incontinence as labeled in the treatment charts. And thereafter, any attempt to now give anticholinergics in the era when Meera Bagron was walking into the country did not do much justice to him. That was 2017. He moved to 2018, he became 57 years young. He had pain in the pelvis. His bike rides were getting over because it was lumpy, bumpy in the city where he continued to live with his son. His lifestyle was getting more restricted at only 56. No diapers actually, but he was deeply into discomfort about the word urine. At that point in time, he moved on to his younger son, and a colleague urologist saw him and gave him cystoscopy, botulinum toxin, 100 units under general anesthesia as an attempt to treat this refractory urgency frequency urge incontinence found on the notes to have small anesthetic bladder capacity and needle resistance to intradetrusor location of the Botox wherever he injected. Post his Botox injection, the charts talk about exacerbated symptoms, and there was not much to do but to catheterize him. He was very uncomfortable with catheter. That was 2018. In 2019, when he became 57 years young, he did land up in the city, and there was only one option to look at what is happening inside. He was very uncomfortable, no catheter, not able to void. Now he had shifted himself to diapers at the age of 57. I wish this video plays. So that's the video sitting at the sphincter, post TURP BNI done approximately 2.5 years ago. And that's a very amateur recording from another phone, and you can see what is happening inside. You saw some degree of debris and aspects that was inside, but we are into the bladder, and that is his bladder. Dr. Sanjay, you can start talking on this.
So the first, I have lots of questions, but the first thing I'd like to start off with is that pain is not a common manifestation of functional obstruction. Yeah. So somebody who has a primary bladder neck obstruction, prostatic obstruction, these problems don't typically present with pain. So if you have pain, you're either dealing typically with a structural obstruction, like a stricture, for instance, in a man, or it's something else. And I would be very hesitant to offer somebody corrective surgery for the outlet if their presentation primarily is pain. In this particular setting, I would probably not have operated this patient without a video urodynamics. So I have many other questions in mind, but certainly anybody presenting with pain, I would like to resolve that. And perhaps if I'm still forced into a situation where I'm operating the patient, be very careful in counseling. I'd also like to know what's the patient's flow when the pain is not there. So assuming that the pain is kind of episodic, is there a correlation between the pain and the flow? Because there are patients who have, when they have pain, they're not able to pass well. When they don't have much pain, they can pass well. So all of these things might have given us a clue as to what we are dealing with. But there are lots of other things I could discuss or ask.
No, true, very much. I mean, your very word, video urodynamics is important. When he strains to pass urine, he's worse. When he has bladder full, he's bad. So he's hovering between bad, worse, and hell. That is where he is, and he is now 59. He's looking at 2020, the year he wants to forget, because he cannot see uro. This is the live case. But Anita, your thoughts on this case, that women only don't suffer with bladder pain or pain symptoms?
Well, first of all, Sanjay, I'm very glad he's under your care and not mine, because here I think the person who's suffering is you, in addition to the patient. So going back to this, it's not been a very nice story. And what we've converted, we've really created a cripple by being overzealous in treating something very well-meaning, but unfortunately it hasn't given us the desired result. And what I do understand is somebody who had voiding and storage LUTs post his BNI is now incontinent. He wasn't incontinent before. And I think that's the worst part of the whole thing, because at a young age, somebody who's neurologically normal and a non-diabetic is in a diaper. And in fact, this is exactly the sob story we should not be creating. And I would, again, concur with what Sanjay Sinha said, that we've done something majorly invasive without evaluating his lower tract functionally. And I wish that had been done as the only thing that I would have definitely done differently, and then taken the subsequent steps depending on what my video UDM or a UDM with EMG or some such evaluation shows. Now that we have somebody who is truly a bladder cripple and he's incontinent, and I presume he has got urgency and urge incontinence and not a sphincteric incontinence, at least now I would 100% want to know what his urodynamic is like. At least a baseline cystometry, though you showed on cystoscopy there are mucosal lesions. I gathered that from the cystoscopy. You did show an open bladder neck. It at least didn't appear stenotic to me.
Absolutely.
I didn't really see the sphincter region, but I presume the sphincter region cystoscopy looks intact and normal. But now is the time we need to do a good baseline cystometry, if nothing else. We still need a voiding diary because he is not incontinent. He's wearing a diaper because of urgency. So I would still want to have a voiding diary or a bladder diary before doing any functional evaluation. These are my immediate thoughts.
Super. So my question to Dr. Mishra, to you, because you raised your hand, he does not tolerate a catheter. His catheter is painful. He doesn't tolerate it. He's better off in diapers with pain, discomfort, painful voiding, painful failure to void, all that functionally, but doesn't tolerate catheter. He has got bladder lesions. Dr. Nagendra, this is a very important point.
Yes, because most of these patients with bladder pain syndrome, they will not tolerate the catheter. So that is an important point you have mentioned, Sanjay. And I would like to know one thing that you mentioned about decreased capacity. So what is the decreased capacity?
So this cystoscopy done in 2019 showed a cystoscopic anesthetic bladder capacity of 290 ml, 290. That was it.
Okay, so that's fair, not very decreased.
That's fine. So, sir, I will move to Dr. Loaz, and that would be possibly close to closure of this because we are close to 3 hours plus. Dr. Loaz, please.
As he's a male patient and has a hypersensitive urethra, which is a typical sign of males' interstitial cystitis, I would perform a local gag layer replenishment therapy by the catheter-free installation method, which prevents the urethra by hurting the catheter. And the patients are very happy with this, and the result can be controlled and followed up by the 2 days urinary diary, which measures the quality of the gag layer.
Should be good enough. I've got what I wanted. I should call this a day right now with time constraints. Thank you, ISU, USI, and the entire team and stalwarts and teachers. Thank you, this panel, which has actually stood by for the entire program. I will close it now.
Yeah. Thank you very much, Sanjay. It has been a wonderful panel discussion, and all the panelists have really contributed a lot to the kind of discussion that you actually meant this case to do. And you see, we have some overseas friends from various places, and I would request all of them to say a few words about the webinar, what they think about it. So I'll start with the first, Dr. Phil Hanno. Is he around?
He's around.
Yes.
Here. I really enjoyed this very much. I enjoyed hearing everybody's opinions. And I thought the cases were extremely interesting. The talks were great. And I'm very happy to have been invited, and enjoyed seeing all the faces I remember from other meetings. Thank you.
Mauro, would you like to?
You have to unmute yourself.
Dr. Mauro.
Sorry. Okay. I would like to thank Rajesh and all the Indian friends and the other speakers, international speakers. Excellent presentation and excellent and interesting discussion. I had a lot of comments on this, but I know that there is not too much time. Probably in the near future, we will have more round discussion. Thank you.
Dick.
Thanks, Rajesh. I think this was an excellent session. Very high quality talks, and I believe that about 1/5 of the world's population of bladder pain syndrome patients are well cared for under the USI. I think it was extremely high quality, and very good discussions. So well done, and thanks for having me.
Thank you. And Lobaz, your words?
Well, if I would say everything was very, very well organized and nice, I'm afraid you will think I'm just telling it because I want to be friendly and kind. No, this was the best ever in my life. Took part in any congresses or meetings regarding industrial cystitis. I'm absolutely impressed. And that's why I like to come to JIPS as well, to Mumbai, because there are so many professional colleagues within one country, which is never in no land on earth to find. So thank you very much to get the opportunity to be here. And it was a marvelous impression. Thank you.
Thank you very much. Thank you very much, USI, Urology Society of India, and the ISU Chairman, Dr. Rajiv Sood, and Vice Chairman, Dr. Arun Chawla. I would look forward to your comments before we close.
Yeah, Dr. Rajesh.
Yeah.
Yeah, before I hand over to Dr. Rajiv Sood for his concluding remarks, Dr. Rajiv TP has some engagement, so Dr. Rajiv Sood will be making the concluding remarks. But from my side, it's amazing. This was an excellent program, very nicely charted out into three different sections. Excellent case scenario discussion. Kudos to international faculty, Professor Hanu and Dr. Dick, Dr. Maros, Lawal Sender, and our national faculty, Dr. N.P. Gupta, Dr. Sanjay Sinha, Dr. Anita Patel, yourself, for excellent presentations from the faculty speakers and informative comments from the expert faculty. In overall, an excellent program. And I hand over to Dr. Rajiv Sood for his concluding remarks. Over to you, sir.
Thank you, Dr. Chawla. This was a great webinar. This was the effort worth of starting the Saturday School of Urology. And I thank all the participants, moderators, and also the expert commentators of all the two sessions, and third session, the panelists. It was wonderful discussion. What can be better than this? I have no words. And Dr. Rajesh Taneja, who is always doing wonders, he has crafted the program so well that everybody has enjoyed and is glued to the screen till the end. And we as the participant and audience has enjoyed the maximum, and we have overshoot by half an hour, but that is worth that. And nobody minds that when the discussion and scientific content is so useful for our day-to-day practice and for our future, and also the updates which have been shared are unparalleled. So this is the important topic which is taken up by the USI, ISU, and Gibbs is working on that. Rajesh Taneja, Nangendra Mishra, and Sanjay Sinha, Sanjay Pandey, and so many of the faculty, they are tirelessly and continuously working on these issues. And I'm very impressed with the first session, where the basic nomenclature and pathogenic ways, and also Hunter ulcers journey given by Dr. Jensen, and also the biomarkers, which were very effectively covered. And this is the time. These biomarkers are very important. You know that now hundreds of biomarkers are there in pipeline for COVID. And we are doing almost 4,000-5,000 trials. They are going on. And these biomarkers are the future. They will guide our the direction of treatment, management, everything. So once again, I congratulate the entire faculty and the team who has participated. I am thankful. to Urological Society of India for giving this slot to Indian School of Urology, and along with me, Dr. Arun Chawla. We thank the technical team and and also Alembic for their unconditional and the grant to conduct
Alkem Urocare.
Alkem Urocare.
Thank you very much. Thank you very much, and once again, congratulations to all. Thank you.
Thank you.
Alkem Urocare, yeah. Ankit, special thanks to you. And thanks to Navneet, the USA office. Thank you. Good night. Stay safe, stay well, sir. Over.
Right, sir. Thank you so much, sir. On behalf of Alkem Urocare, just want to conclude. Saturday School in Urology was initiated with the sole objective of dissemination of scientific knowledge and sharing of best clinical practices in the field of urology. We sincerely thank in this 6th edition once again to Urology Society of India, ISU, Dr. Rajiv TP, Honorable respected Dr. Anand Kumar sir, moderator for today's session, who was flawless, and thank you so much, Dr. Rajesh Taneja sir. Thank you, Dr. Rajiv Sood sir, and Dr. Arun Chawla sir, the great chairmen, experts, faculties who have taken out time, put in so much effort in making this 6th edition of Saturday School in Urology a great success. We've had close to around 300 August audience urologists. And I believe this is amongst the 2 more webinars which are co-parallelly running across the country. So this will be available, the entire webcast will be available on the USI website as well as alkemurocare.com, where the previous 6 webcasts are also available on alkemurocare.com. Thank you so much, Banyan Tree Communications, as well as the Alkem salespeople team, who have connected with most of the urologists across the country and have got all the interested urologists as audience, as an active participant in this Saturday School in Urology. Sincere thanks.
Bye-bye.
Bye-bye. So we go. Have a good night.
Thank you.
Thank you.
Thank you.